Welcome to the International Arrhythmia School for the inaugural online class in conjunction with the Society for Cardiac Robotic Navigation and the annual awards session organized by IWAS 2021 and SCRN, supported by Bristol Myers Squibb, Pfizer, Biotronic, Bayer, and Sunnybrook Health Sciences Center, and endorsed by World Society of Arrhythmias and Canadian Heart Rhythm Society. Good morning and good afternoon, depending on which part of the world you currently are, to all of you who are participating in this virtual online event. We are very pleased to have so many of you online. We have currently 144 participants, and we are looking forward to spend some valuable time with you on some very interesting topics and key learning objectives, which Dr. Crystal will dig a little deeper into in just a few moments. We are very excited to present to you the very first inaugural online class of the International Arrhythmia School. We are hoping for a very interactive program. We encourage you to contribute to this event with your observations, questions, and remarks. Please note that making recordings during the event is prohibited. Also, we kindly inform you that physicians may discuss or present information on industry products, product claims, or techniques that may not have approval or clearance in all geographies. To benefit fully of the program, we ask you, our audience, to actively participate in the event. Please use the chat function in the Zoom control panel to pose questions or remarks that you would like to be discussed in front of the audience. Our moderator will pick up these questions at an appropriate time in the presentations. For questions you would like to be answered by the panel in writing and does not require to be part of the discussions, please use the Q&A function. Our panel members will reply to you in writing. Should you drop off from the event, you can always get back in using the same link. It's now with great pleasure that I introduce to you founder and chairman of the International Arrhythmia School, Dr. Eugene Crystal.
Okay, so thank you very much for attending this event, which is happening now on 18th consecutive year. It is originally called Winter Arrhythmia School. We argue that there is a winter somewhere at the moment, so we kept the name for now. It's our first digital version. We were lucky last year. In fact, we probably were the last, one of the last events which were conducted in February of 2020 when certain parts of the world were already suffering from pandemic. And we were optimistically waiting for the pandemic to end. After waiting and learning that it's not going away anywhere anytime soon, we decided to run a digital version. We kept two principles to focus on new things and improve our expertise in routine work in patients with arrhythmia. And we decided to divide this 2 days event into the 3 shorter events, which would be 3 or 4 hours long and will be run on 3 separate occasions. We are bringing session on invasive treatments for autonomic disorders, which is probably one of the most exciting news in electrophysiology recently, which was born and developed to the today's form on the edges of our understanding of autonomic disorders and abilities of mapping, on remote monitoring, on palliative care, and we also will talk about best papers in EP robotics. This event is accredited and we will plan back to you with additional sessions on refinements of device therapy, ECG training, automation, telemedicine, and more. I want to thank upfront Marluz and Petra from Meeting Pulse. They're based in Europe, John Kapagiridis and Lisa, who is our Toronto team, Dr. Ambrin Saida, who helped us with everything related to accreditation. I want particularly thank Suzette Turner, Arjan Baranchuk, and Maria here at Sunnybrook. And I want to thank Robotic Society team of Pete Weiss, who will be new incoming president of the Robotic Society, Pedram Kazemian, Gurjit, and Ali. I want to thank all sponsors and all supporters. And I was thinking about one optimistic slide of how small and simple coronavirus is comparing to the real world and the way it looks. And without further ado, I will introduce our chairs for the first session, who is Dr. Satish Raj and Dr. Richard Sutton, who are gurus in autonomic cardiovascular physiology. Please.
Thank you, Eugene. Thank you for inviting me. I'm happy to be chairing this session, as pacing in vasovagal syncope has long been a topic of my interest, and more recently, cardioneuroablation. Now, we're very fortunate in having Satish Raj as my co-chairman from Calgary. And indeed, we're very fortunate to have Tolga Aksu from Kocaeli in Turkey, who is a rising star in ablation of arrhythmias and has in the last few years turned his attention to cardioneuroablation for vasovagal syncope and other, shall we say, bradycardia conditions. Tolga is going to address us on the subject of cardioneuroablation, and I suggest that he starts now when he's ready. Tolga.
Thank you so much, Professor. First of all, I would like to thank Professor Crystal and Professor Baranchuk for the kind invitation to this excellent meeting. This is a great honor for me. I would like to change my slides. Sorry, I have a problem.
If you go to with your mouse to the
I guess now I fixed the problem. This is a great honor for me to be here at this time, and today I will try to briefly discuss cardioneuroablation strategy in patients with vasovagal syncope, and this is my disclosures. Actually, as you know that according to latest ASC guideline, in case of severe or recurrent reflex syncope cases, in the first step, we should differentiate low blood pressure phenotype, because we know that in patients with pure vasodepressor type reflex syncope or in mixed type cases with low blood pressure phenotype, we can try some medications like fludrocortisone or midodrine in the first attempt. And if we see a clear prodromal symptoms before occurrence of syncope episode, we can select counter-pressure maneuver or tilt training in these cases. But in case of dominant cardio inhibitor response, actually we have only one option, and this is cardiac pacing. But in the next presentation, Professor Murilla will explain it with details. But I just want to mention that if you look at the published studies like Spain issue 3 or recently published bioscience studies, you will see that only patients older than 40 years old were included in those studies. So we don't know anything about the effect of clear effect of cardiac pacing in younger population. Actually, cardioneuroablation is catheter-based autonomic modulation of intrinsic cardiac nerve system. And we know that intrinsic cardiac nerve system contains both efferent parasympathetic and sympathetic motor neurons, afferent sensory neurons, and local circuit neurons. Actually, we usually think that there are some ganglionated plexus which contains grouping ganglia around atria, and within this ganglia we usually see parasympathetic neuronal bodies. So the main target of cardioneuroablation should be parasympathetic component of autonomic nerve system. But today, by using immunohistochemical staining, we know that we also ablate and denervate sympathetic system by using cardioneuroablation strategy. Actually, to understand in which case we can use cardioneuroablation, we should demonstrate the parasympathetic overactivity component in occurrence of this disease. For example, if you look at the pathophysiology of vasovagal syncope briefly, we know that after occurrence of any trigger activity, we see a decrease on left ventricular filling pressure, it increases sympathetic tone, cause first ventricular contraction, then stimulates C fibers, and finally we can see three different responses. In the first time, the main cause of global cerebral hypoperfusion is bradycardia due to parasympathetic overactivity, and which is called as cardioinhibitory type. In the second arm, we see hypotension due to sympathetic withdrawal, which is called as vasodepressor type. But in a great majority of cases, both sympathetic withdrawal and parasympathetic overactivity contribute occurrence of global cerebral hypoperfusion. So, in the first slide, I said that the main target for cardioneuroablation should be parasympathetic. So, in all patients with cardioinhibitory reflex syncope, or in great majority of mixed tip cases, if we can demonstrate the contributor role of parasympathetic overactivity, we can treat these clinical conditions by using cardioneuroablation strategy. Actually, GP concept defines that there are some grouping autonomic ganglia around left and right atrium, and we can detect these sites during electrophysiological study. But today we know that actually there are epicardial ganglia and some postganglionated neuronal fibers from this ganglia to sinoatrial node, atrioventricular conduction system, or a different part of ventricular area. So during catheter ablation, we ablate both this epicardial or autonomic ganglia plus postganglionated neuronal fibers. So we have some human anatomical spaceman to demonstrate possible localization of this epicardial ganglia. And if you look at here, actually we see a very distributed localization around left and right atrium, but I would like to indicate that the great majority of these epicardial ganglia are located between right atrial and left atrial structures in midline area. So the great majority of epicardial ganglia are located in interatrial septum area between superior vena cava and right superior pulmonary vein, and around coronary sinus ostium. As another important point, in a well-designed study, Van Dickel et al. Studied the tilt testing characteristics during occurrence of syncope episode. And if you look at here, they demonstrated that cardioinhibitory response usually starts before occurrence of bradycardia, like in here. Actually, during tilt testing, we usually see a stepwise increase on heart rate levels, and then we see a steep decrease on heart rate, but we usually see the starting point of cardioinhibitory response before occurrence of very low heart rate. This is why classical pacemakers or even rate drop response pacemakers are not effective in great majority of reflex syncope cases, because you have to detect the event in the earlier steps before occurrence of significant bradycardia. But if you use cardioneuroablation strategy, if you look at here, before cardioneuroablation, we can check the vagal tone or sympathetic tone, and we see a clear increase on vagal tone and a sympathetic withdrawal during reflex syncope episode. This is a classical mixed tip reflex syncope, but after cardioneuroablation, we don't see any parasympathetic overactivity, and we don't see any sympathetic withdrawal. This is why we can fix the problem by using cardioneuroablation strategy. If you look at the published data, actually, Professor Pachon created the technique in 2004, defined the usage of this technique in patients with Vagally mediated bradyarrhythmia. And in their long-term follow-up study, if you look at here, they studied with a very young patient population. The mean age was 32 years old. And as another important point, in great majority of cases, there was cardioinhibitory reflex syncope. In only 5% of cases, there was mixed tip syncope. So they demonstrated a very good success rate after cardioneuroablation strategy at the end of 40 months follow-up. There was no new syncope episode in almost 95% of cases. After that, Professor Yan Yao and team from China published the largest series about cardioneuroablation in vasovagal syncope population They just mapped left atrial ganglionated plexus site, and by using high frequency stimulation, they detected the GPs and ablated all left atrial major GP sites. And if you look at here, there was 115 patients in this study, and they demonstrated that syncope-free survival was higher than 90% at the end of median 18 months. But as an interesting point, in their study, actually, in great majority of cases, there was mixed reflex syncope, contrary to the previous patrons' experience. And I think that the most surprising part, there was also some pure vasodepressor reflex syncope cases in this study, and they demonstrated a similar success rate in vasodepressor reflex syncope cases as well. And then we saw a small but important study studying the effect of right atrial GP ablation, because you know that some electrophysiologists have some concerns related to transseptal puncture. So Leonardo Colla and team studied the effect of right atrial GP ablation in a similar patient population, but there was only 18 patients in that study, and they demonstrated almost 85% success rate for syncope-free survival at the end of 34 months follow-up period. But as an interesting point, after 24 months, we saw some decrease on heart rate levels, and we saw that heart rate variability parameters demonstrating parasympathetic effect changed to the baseline levels after 34 months. So I think that it may be related to reinnervation due to one-sided ablation attempt. Let's check our technique and our results in this patient population. Actually, in our first study, we used a combination of Professor Patron's fast Fourier transform analysis plus high-frequency stimulation. And then in the second study, we compared this combination strategy with a simple method. In the next simple method, we just try to detect these fragmented electrograms around left atrium and right atrium by changing our bandpass filter. And all fragmented electrograms in a region that is consistent with probable localization of GPs were tagged as ablation target in the current strategy. And at the end of this comparison study, we found the shorter procedure and scopy time in EGM-guided strategy with similar effect on heart rate variability parameters and syncope burden. So now we just use fragmented electrograms without using any additional equipment to detect the localization of GPs. According to our fragmented electrogram strategy, you can see the possible localization of GP sites around left atrium and right atrium. Again, it is important, the great majority of epicardial ganglia are located in this midline area between left atrial and right atrial structures. There is only 3 distinct GP sites except this midline area, the left superior GP between left superior pulmonary vein and left atrial appendage. The other one is Marshall tract GP. If you remember the possible localization of ligament of Marshall, this is the endocardial part of this ligament, and the last one is left inferior GP located in the posterior wall of left inferior pulmonary vein. And then we published our largest series, and as an important point in that study, we checked the tilt testing in all cases, not just before ablation. Actually, we checked the results after the cardioneuroablation procedure at 1 month and at the 6 month of follow-up. There was 51 patients. In all cases, we documented significant asystole by using tilt testing. And at the end of the follow-up period, syncope-free survival was almost 95%. And we checked the Holter characteristics as well in all cases, and we saw some accompanying bradyarrhythmias like functional AV block, Vagally-induced bradycardia, or pauses, or Vagally-mediated atrial fibrillation. But after cardioneuroablation strategy, we completely eliminate all these different bradyarrhythmia forms during follow-up Holter recordings. And then recently we published the first case control study of cardioneuroablation strategy. We compared cardioneuroablation strategy with a conventional treatment method consisting of physical counter pressure maneuvers and some medications. And at the end of the study, we found that cardioneuroablation caused A 77% relative and 36% absolute risk reduction of 4-year syncopal recurrence rate. And this year, we submitted an abstract to HRS. We compared permanent pace and cardioneuroablation in cardioimperative vasovagal syncope cases. There was one cardioneuroablation patient and 101 pacemaker patient, and we find a similar success rate during 1-year follow-up period. And our suggestion for vasovagal syncope on the basis of this data, in all cases with younger than 40 years old, we think that cardioneuroablation should be the first option because we have no data about cardiac pacing. But in older patients, there might be a possibility for a structural involvement of sinus node or atrioventricular conduction system. So I think that cardiac pacing might be a better option for these older cases. In other patients, you can select your treatment option by talking your patient and your family. And last point, in mixed tip cases, you should try medications first, midodrine or fludrocortisone, and then decide to cardioneuroablation or pacing based on treatment results. Thanks for your attention.
Thank you, Tolga. That was a great and very fast overview. I think next time we'll have to talk to Eugene about giving you a whole hour so that you can slow down and can absorb the data a little faster. There's going to be time for questions and a discussion afterwards, but first we'll have our next speaker present. Carlos Murillo is currently my head of cardiology, so I have to be nice to him, but really objectively looking back at his career, it's truly remarkable. He has been a leader in cardiovascular autonomic regulation and studies. He's been involved in vasovagal syncope trials dating back 20 years. He has been on steering committees and led atrial fibrillation ablation trials for many years. And noted in the Spain trial, I loved seeing the authors consisted of a bunch of Spanish microphysiologist and Carlos. Really, he's a person that this moment has been waiting for, where all his work has really led up to the junction of autonomic physiology, ablation, and pacing. And with that, Carlos is going to try and defend the pacemaker that Tolga besmirched a few minutes ago. Carlos?
Thanks, Atish. I think I'm going to have to change my review on you after that introduction. Anyways, well, thank you very much. It's a pleasure to be here. I'd like to congratulate actually Eugene for taking the steps and making this meeting happen. I was provided this this title that I didn't make up myself, Decades in Denial for Pacing for Vasovagal Syncope. So we'll try to deal with that. Now here are my my disclosures. I obviously have been very involved with vasovagal syncope for a long time, and have been part of the reviewer or author of many of the guidelines, or a co-author. I've been part of all the vasovagal VPS 1 and 2, all the post trials, actually the issue, the Spain, also interested in cardioneuroablation. I'm so committed to research that I actually have randomized within the post trials my 2 ex-wives. So I still haven't offered cardioneuroablation or a pacemaker to either of them, but that's how committed I am in this case. So the way to look at this is first, let's look at a case. It's a 41-year-old retired Democrat electric engineer. It was totally well. It was on no medications. He was discussing with a recent friend that turned out to be an electrophysiologist about the election there with Trump and Biden. So he got a little bit festered and flushed, and he had a syncopal episode. He has fainted in the past in Afghanistan, and at the same time when he saw carnage. So pretty typical history. Now, what do you do with this person? Just get some salt, do some counter-pressure maneuvers, get a Holter, a tilt, or whatever, put a pacemaker, ask Professor Sultan, consult the syncope clinic. The truth is that I wouldn't have done anything to this guy, but you know how things happen. He was referred for a tilt. They first consulted the syncope clinic. I'm usually not around. Well, now with the pandemic, I'm around a lot, but here I was doing a randomized trial of the color of the hair in orthostatic intolerance. At any rate, this patient ends up getting a tilt table test, and you can see here, suddenly with not a lot of drop in blood pressure, he just does a long systole that in this case was over 30 seconds. All this movement here is because he obviously had a seizure because of hypoxemia. So 40-year-old guy, does he need cardioneuroablation or does he need a pacemaker? And there's another patient that I saw recently when I was on service a couple of weeks ago. There's a 78-year-old retired oil engineer that has mild hypertension, is only on amlodipine. And he, in 2016, while he was swallowing a cold beverage, fainted, total loss of consciousness. Then when he was getting out of a hot tub in Palm Springs, he had had some drinks, also fainted. Then he was swallowing another cold beverage in 2020 in March and had another episode of syncope. Same thing in July. And then he's referred for a tilt table test. The tilt table test really useful in this case or not, that's something that we could leave for the discussion later. But he comes to our autonomic lab that, we do a carotid sinus massage. This is the right and this is the left, supine and upright. I'm not going to go into the details. He felt a little bit lightheaded. His blood pressure drops significantly. He's got a drop of almost 30 to 40 millimeters there. Not a lot of bradycardia, so mostly vasodepressor type of a carotid sinus hypersensitivity. He does not have carotid sinus syndrome as far as we can tell. He gets into the tilt table test. And again, you can see that the blood pressure kind of drops slowly. And here are the data more in detail. You can see that after 6 minutes, he feels a little bit short of breath and not very well. Blood pressure is coming down. His heart rate doesn't really change that much. After nitroglycerin, his blood pressure, bottoms down. His heart rate is not that bad, and he has syncope. But he's pretty sure and says, well, I don't really feel like this when I get these episodes. So we decide that, okay, well, he gets syncope when he drinks cold water, so let's give him some cold water. And he's standing there on the tilt table test. We give him cold water, look at his blood pressure. That's the first thing that you can see happens. About a 30, 20 something millimeter drop in blood pressure. And then he does an asystole of 3.6 seconds. Okay, so now what? I will leave that for the discussion. As you know, I've been involved in syncope for a long time, not as long as Richard, but pretty close. And this was one of our first papers that we were trying to modulate vagal tone with disopyramide. But I'm not showing that for this reason, but mostly because we also showed that, when you tilted repeatedly people, you pretty much kind of get rid of the reflex in most. So some people said that we said in the paper that we were promoting tilt table training. We didn't, but I take the credit. Now, the fact is that we have looked into this, and you can see here when we published this back with Dwayne Neckberg some time ago, we were looking at sympathetic nerve traffic also, and you can see that the sympathetic nerve traffic kind of shuts down, but there's bradycardia, hypotension. So where does this start? When would pacing work? These are things that we need to kind of look into more detail, and the recommendations have gone back and forth depending on the data that we have. As you know, we had interesting data back in VPS1, in which I also participated. Stuart and Bob Sheldon were the fathers of this trial. You can see that patients were randomized to pacemaker, no pacemaker or pacemaker, and people that got a pacemaker, same with the VASES, Professor Sutton there. Pretty much no one actually faints after a pacemaker, even if you don't do anything. So this is important to see. And if you do compare it to medical treatment, whatever it was way back in the 2000s, not very effective. It seemed to be that people that got a pacemaker pretty much never fainted. So that's interesting because when we did the double-blind trials, well, actually people continued to faint, and there was no difference in both the SynPace, the European, and the VPS2, the Canadian trial. And you can see that's actually a 30% relative risk reduction. So what's this? This is really a huge placebo effect, expectation effect, whatever you want to call it. And now we understand that. So I would say most of what we're seeing in the cardioneuroablation trials, surely only expectation and not real. The ISSUE trial that we all participated in was a little bit more of a complex trial, a long screening. They screened almost 100 patients, ended up randomizing a small proportion. And you can see that when the pacemaker was on, there was a very significant relative risk reduction, 57% at 2 years, which was quite powerful. So when we look at this, which is interesting, those that had a positive tilt table test did not benefit from the pacemaker. So what does this mean? I don't know, we can leave that for the discussion also. And then comes the CLS pacing, which according to these two trials, which were randomized but not double-blinded, and placebo, you get a CLS, you're never going to faint in your life. This is too good to be true. But again, there was another study from Palmisano that did a crossover study looking more at the physiologic response. And really what happens is that what we are able to gain with DDCLS is delaying the time of onset of syncope. And obviously this study was not looking at that part of recurrence of syncope. Now, even leadless pacemakers appear to be great for this. And you can see this publication from some of my good friends in Kansas City and around the US, where this is not a randomized study, 24 patients at single chamber, leadless, and apparently, nobody has syncope after you get a pacemaker. But remember, this is your survival curves. This is really great. Nobody has syncope. But I remind you, this is from the VASIS study. You can see this is the pacemaker, people, no pacemaker, exactly the same. So what would have happened if you actually had done an intervention in this trial? And look at what Tolga shows us from the father of cardioneuroablation, which is Dr. Pachon. Same thing. So come on, this is probably not a true effect. There is, of course, an effect, but it's not this big. So I would say that 70% of this is placebo effect. Now, we did the Spain trial, and as Satish mentioned, we did this with my good friend Gonzalo Arones-Quivias and my other good buddy, Dr. Angel Moya. I was the only non-Spaniard, but with a Hispanic name, so that's why I qualified for the trial. This was a dual chamber CLS trial in which we basically, each patient served as their control. It's not a big trial like most of the pacing trials, but it was a double-blind, crossover, randomized trial. So now the other thing that's important to keep in mind when you look at this data and compare it with the next trial that was just recently published, the BioSync, and we will go there in a minute. Now, everybody got a tilt table test. As you know, I've tilted myself many times with many drugs. Isoprel, nitroprusside, idurofonium was actually really bad. I almost fainted on that one, but I've never fainted on a tilt table test. So this was how we selected the patients. That's the protocol for the pacing. And this could be considered like an aggressive CLS protocol. I don't think we know exactly which is the best, but this would be kind of the recommendations. So the group that was a sham group, it was lower rate was 30 pace per minute with pacing polarity was unipolar, etc. And you can read this faster than I can. Now, things to keep in mind when we look at this trial and the Brignole trial. Age. Our patients were not that old. Well, maybe it's because I'm around that age and maybe I feel younger, but this was the age 56 with, a standard deviation of 10. So there were patients that were probably early 40s. A high proportion of patients had lots of syncope during the last 12 months. So almost 5 episodes in the last 12 months. Almost everybody had a systole during tilt, and the duration of a systole was long, was a mean of 15 seconds. And this is important to see when we look at the next trial. Why? Because as you get older, the duration of a systole is shorter. We know that. So it's important to keep this information in mind. Now, the other critical point to keep in mind is what was the primary efficacy endpoint? Our primary efficacy endpoint, and this can be discussed, and we had a hard time trying to get this paper accepted because of this, but we did have a co-primary efficacy outcome. So usually every single trial is time to first event. We thought that that does not really mean much from the clinical perspective, and we felt that more than a 50% reduction in syncope and the overall density burden of syncope was what was important. And this was our primary efficacy with a co-primary efficacy, which is the usual comparing time to first recurrence on both types of pacing. And you can see there was a huge reduction in the syncope burden, and over 70% when they were initially randomized to DDD-CLS versus sham and crossover to sham, or when they were initially sham, then crossover to the CLS, in which everybody had a greater than 50% reduction. In addition, if you look at the co-primary outcomes, there was a huge reduction in syncope and time to first recurrence, regardless, and obviously benefiting DDD CLS compared to just the sham control. Now, yes, to put this into perspective, here is the data. There's a huge reduction. This is the odds ratio. So this is an 89% relative risk reduction. You don't get that a lot in any trial in cardiovascular diseases. Now, the other thing is that so there's an 8-fold increase in risk when you're on the sham. Absolute risk reduction of 37%. Only 2.7 patients needed to prevent either a 50% reduction in burden or time to first recurrence. So both, because both were, this was part of the co-primary. So definitely a strong trial that shows that. If you look at meta-analysis, again, this is something that favors CLS over rate drop. There's no direct comparisons here, but this is something that has been shown. But important to see that, you know, you have to have a systole on these patients, or at least significant bradycardia. Otherwise, they're probably not going to benefit that much. Now, again, the latest trial that has been published is the BioSync trial, led by my good friend Michele Brignole and the group there. And this was just recently published in the European Heart Journal, 128 patients, so not a huge group. So patients were randomized either to the DDD CLS or ODO, 64 more or less in each group, and analyzed by intention to treat. Again, age, this was an older crowd, 53 in Spain, 62 in BioSync. Number of episodes of syncope during the lifetime, about 5. During the previous year, 3. We're more around 5. And this is the duration of the systole from the tilt table test, which was a little bit shorter as predicted just because of age. So important to keep that in mind. Now, the primary endpoint, pretty much similar to what we saw in the Spain trial. This is at 1 year and this is at 2 years. So overall, a 70-something% reduction, relative risk reduction, and only 2.2 needed to treat to prevent an episode of syncope, and actually no other differences. Now, is this going to work on everybody? Well, probably not, because now we know from this interesting study from Sal, I think, in Europe, is looking at the time of a systole and when you actually lose consciousness. And sometimes people actually have late asystole, which is not related with the loss of consciousness. So maybe that is a population in which a pacemaker like CLS may not necessarily work. Now, this is an algorithm that Tolga and Mandrola and Satish have proposed. You know, if you're less than 40 CNA, I say we're not ready for CNA. We need a sham-controlled trial. Greater than 40, probably DDD CLS. Leadless, I think we don't have any data, and that would be probably the settings that we need for this. So I think that in conclusion, should pacing CLS be first-line therapy? Well, you know, we still have to look into that. From the supplementary analysis in the BioSync, how many people are actually at risk for this? They say that, you know, 25% of the general population over 40 are going to have reflex syncope. So they estimate that anyone between 280 to 630 eligible patients for cardiac patients in every 100 inhabitants. Even better, we can actually treat our dogs. These apparently, dogs and cats have vasovagal syncope with these pacemakers. So I think that we've not have 30 years of denial. We have 30 years of a lot of data that is very important for us, and that obviously we have moved forward in this field, and we have significant evidence that this works in a very specific group of patients. Thank you very much.
So that was great. I'm going to invite both Carlos to keep his camera and microphone on, and invite Tolga back as well. We have some questions that have been thrown into the chat box. Some are technical and some are big picture. We don't have a lot of time. I'm going to sort of go with a big picture question that was thrown in there and expand on it. So the question from Dr. Zerpa is, what would be an ideal sham protocol proposal for CNA versus a CLS pacemaker with the various ethical issues? And I'm going to expand that a little because I think there are lots of issues that come out in that. One is, you know, it was correctly pointed out that the pacing recommendations are for patients over 40. Is that because it's dangerous under 40 or lack of data is one part? And two, before we get to a comparative effectiveness, do you guys think that, as I think Carlos suggested, that maybe we need to have a sham just of CNA in some group? And I'll throw that out, maybe let Tolga start.
Actually, I think that I totally agree with Dr. Murillo about we need a sham control study to say clear effect or absolute effect after cardioneuroablation. But I think in one arm we can check the electrophysiological parameters or something like that. And because I don't think we need transseptal puncture in both cohort. But actually, the main problem with cardioneuroablation strategy, we still don't know the right technique, because different groups define different techniques. So we just select one technique, and we will try this technique in one cohort, and in the other arm, we will check electrophysiological parameters. Maybe we use general anesthesia, and the patient will blind of treatment option. But we need to discuss deeply.
Yeah, I think the problem is that, first, pacing is pretty easy. Dual chamber pacing, and you select, CLS or not CLS, that's another discussion. And it's very standard. So we don't have a problem there. The problem is with cardioneuroablation, there's different endpoints, there's different techniques, and we don't know the true effect. We need to determine what is the true effect of this intervention. It may be great, I'm not denying that, but we need to determine it. Is cardioneuroablation going to be useful in a 78-year-old patient that I showed you? And actually, for matters of discussion and time, what happened with this guy is that, after that, I just said, well, with the data that I showed you, I'm just going to give him Midodrine and see how he does. And then he comes next time that I'm on call, he's in the hospital in the orthopod ward, because while he was taking his Midodrine pill in the kitchen standing up, he choked on the pill, fell backwards, and broke his L1, fractured his L1. So now he got a CLS plus Midodrine, which I think is what's going to happen with a significant proportion of older patients. Because the fact is that we still know that even with CLS, there's 30% of these people that continue to faint. And probably there's dual mechanisms in there. So Adrian was asking, in refractory syncope, is a pacemaker first line or after Midodrine and fluorocortisone? I think that we need to actually look at the data. And here's where tilt table with, continuous monitoring of blood pressure, cardiac output, cardiac index, and the other things that we do will be helpful to try to figure out if only the pacemaker or a combination would be useful in that population.
Dr. Sutton, you've been involved in this space for 25, 30 years and really been the leader. Can you share some of your thoughts on where we are and where we're going?
I think we've made progress, albeit slow. And we started badly by making comparisons between an intervention, implanting a device, versus nothing. And there was a lot of placebo effect. By 15, 20 years, we got to the issue 3 study, which was real progress, because it showed without a doubt, in my view, that pacing had effect in vasovagal syncope in older patients. And since then, we've advanced further with the Spain study and the BioSync study. But even the Spain study, they are older patients. I mean, they're younger than the others, but so we don't know what's going on in the younger patients. A question was asked a few moments ago by you, Satish, was the question is, are we lacking data in young people, or we think it's dangerous pacing in young people? Well, my answer to that would be it's both. We don't have any data, not any really, except some of the leadless pacing group. And their follow-ups are very short. I mean, maximum 12 months in most cases. That's not good enough for vasovagal syncope. We need 2, 3, 5 years really to be sure of what's going on. And the other thing is that putting a pacemaker in somebody is pretty safe, but there are quite a lot of complications that occur over the duration of pacing. And if you put pacemakers in young people, you'll get more problems than if you put them in old people because they're more active, especially with leads. Without leads, maybe it's better for the young people. But with leads, they get broken. And so pacing is not free of problems even after successful implantation and the lapse of some weeks or a month or two.
There's a question just building on your not free of problems. So just to defend the pacemaker, actually not so much defend the pacemakers, besmirch its opposition. Dr. Stearns has asked a question about long-term complications following cardioneural ablation. And he was specifically asking about whether a decrease in vagal tone could affect cardiac function over time. I'm going to expand that to say that one of the great things about AFib ablations, looking at it from the outside, is that it's a business generation proposition for my ablating colleagues, because it seems to generate its own set of new arrhythmias that you have to go in and ablate some more because of the new tracks that you create. Is that a concern here, or are the cardioneural ablations, the locations far enough apart that you're not setting up new paths for reentry or future arrhythmias? So are we potentially causing harm, I guess, broadly speaking?
Yeah, but let me jump on that one. Satish, obviously we've changed the way we do AF ablation a lot, and we're not getting all those issues anymore. Now, I guess the questions are that we've always said that, heart rate variability and increased vagal tone is good, healthy, protects against sudden cardiac death and things like that. Are we changing that natural history in younger people by getting rid of heart rate variability in this population? I don't think we know. We will, but we need to follow these patients. These patients need to be followed very closely, because we don't know if we are going to precipitate sudden cardiac death, heart failure, who knows what other untoward effects, because we pretty much get rid of vagal tone. Now, the fact is that, as Tolga showed, some people do have reinnervation, which also happens after cardiac transplant. So there's a lot that we still don't understand there. And as far as pacing in younger patients, yeah, I have done that after very reluctantly in patients that have been very refractory, that have actually put an implantable loop recorder and showed some significant pauses. Some that have actually younger, that have had, this ictal syncope that is more centrally mediated by epilepsy, and the amygdala, and they've done well. But again, we don't have data because we're reluctant in putting 2 leads in a 21-year-old that is going to have to live with that for another 60 years and have who knows how many rechanges, how many extractions of leads. That's why we have been reluctant. But I don't think that it doesn't work. It works in a population that probably has the same. As a matter of fact, younger people have longer pauses.
Yes.
We know that.
Yes.
Tolga, do you want to chime in?
Actually, as last words, I would like to indicate that in younger patients, we have no clear option. For example, we are talking about midodrine or fluid cortisone, but in cardioimperative reflex syncope cases, no data about midodrine or fluid cortisone or pacing. So yes, I totally agree. We need a sham control study, but I think that in younger patients, especially if we see a lot of syncope episodes, for example, in some of our cases, we see 3 or more syncope episodes in every week. So I think based on the published data, I think we need an expert consensus statement for cardioneuroablation in younger cardioimperative reflex syncope cases, because pacing data is not enough. So we should do something for these young cases, because I have got a lot of consultation all around the world about this patient group. And after cardiac pacing implantation, we see a lot of syncope recurrence, even with a closed-loop stimulation system. So I think this patient group is not easy to prevent reflex syncope episode. I totally agree about long-term consequences or complications, but actually I try to explain that we also ablate sympathetic system, because there is no difference between sympathetic and parasympathetic neuronal fibers. They are in the same area actually. So we don't just ablate parasympathetic system with this technique. Actually, we also ablate sympathetic system and sensory system as well. This is why Yanyo found a similar success rate in patients with vasodepressor reflex syncope cases. Possibly they ablated these sensory fibers. So I don't think we will see any problem with sudden cardiac death or something like that in future, because we also ablate sympathetic system.
But your greater effect is on the parasympathetic. I think all the evidence is pointing in that direction at the moment. I'd like to go back to something that Carlos was saying a moment ago, and I'm reminded of the Atrami study. And the Atrami study was post-myocardial infarction, which essentially knocked out the parasympathetic. And patients did badly for that loss. So that's why I think we have to have a long follow-up here to know what the effects are later.
I want to thank both speakers and my co-chair, Dr. Sutton. This was a great session. I learned a lot in a very short period of time, and I think that if we had more time, I suspect we could go on for another half an hour with a great discussion. Dr. Crystal, thank you for inviting us, and let me hand the reins over back to you.
Thanks, guys. Great discussion and absolutely fascinating area. And I think it's opening so many new options for us to treat the patients. My personal comment is only, and that's something which I don't have experience yet with, is that there is an option of temporary permanent pacing now, which is increasingly kind of common. And I think for the patients with a frequent syncope, a transient use of the device, just give it a run and see if it works, may be a very good option. Anyway, we'll have to move to the, I believe, a break now. And it will last about 4.5 minutes. Thanks.
Welcome back after the break. I'm just waiting shortly for Dr. Crystal. Just a few moments, please.
Hi, Suzette.
Hello there. Oh, hi, Abhishek. How are you?
Good. Good to see you.
Same here. Nice to see you. I can see you have a lot of light.
Yes, we do. Hi, Valentina.
I'm very happy to announce the co-chairs, Dr. Abhishek Laj-Farkash, Director and EP at the Pacing Unit, Asuta Ashod from the University in Israel and Secretary of the Israeli WG on Pacing and Electrophysiology of the Israel Heart Association, as well as Dr. Suzette Turner, nurse. I'm sorry, Nurse Suzette Turner of the Sunnybrook Health Sciences Center in Toronto. Thank you for your time here, and giving the word to you.
Good morning and welcome. First, I'd like to acknowledge the leadership of Dr. Crystal for putting this virtual session together, combined with the hard work of the planning committee. I'm delighted to be co-moderating with Dr. Abhishek Laj-Farkash. We're excited to have you join us. Thanks to our speakers for virtually being here. And for this session, The Art of Device Therapy, we will have 3 talks with 3 outstanding speakers. Recognizing the effects of shock reduction as a primary prevention, ICD as our first objective. Second objective, reviewing the interaction between mobile devices on pacemakers and defibrillators. And the third objective, discussing palliative care in patients with cardiac implantable electronic devices. I will start by introducing Dr. Valentina Kutifa. Dr. Kutifa is an associate professor of medicine at the University of Rochester Medical Center, Rochester, New York. She holds a PhD in cardiac electrophysiology, a master's in healthcare management, and a certificate in clinical research from Harvard Medical School. She has research interests in cardiac arrhythmias and sudden cardiac death. Her work encompasses a wide variety of studies related to diabetes, ICDs, CRTs, echo, and innovations in technology, including wearable devices, SICD, LVAD, and wearable technologies improving healthcare delivery. Welcome, Dr. Kutifa.
Well, thank you so much. And I just wanted to thank the organizers and the chairs for the invitation to have me present today on shock reduction in primary prevention ICD. These are my disclosures. And I'm just going to start by saying that we all know very well that implantable cardioverter defibrillators are saving lives. One of the first Mediated studies that Dr. Moss and my group conducted here at the University of Rochester showed in about 200 patients that those who had a previous myocardial infarction and a severely reduced ejection fraction benefit from an implantation of an ICD. And this was later extended to a wider population of post-ischemic, post-MI patients. And subsequently, the SCOTAP study also showed that not only ischemic, but also non-ischemic patients with a severely reduced ejection fraction, heart failure symptoms, without any previous ventricular arrhythmias, benefit from implantation of an ICD. So today's guidelines, both the US, the European, Canadian guidelines, suggest implantation of these devices in these patient populations. But we also know that ICD patients do have a relatively high rate of both appropriate and also, unfortunately, inappropriate ICD shocks. These are just some data from a few of these randomized trials, as well as from a registry study showing that the rate of inappropriate ICD discharge was between 9 and 17%, and the rate of appropriate ICD shocks was between 21 and 38%. And when we looked at inappropriate ICD shocks in our Mediated study, we found that a very high proportion of these shocks were between 170 beats per minute and 200, and only a few of them had a very high heart rate actually. We also know that inappropriate ICD shocks are associated with adverse outcomes. This study showed in a large cohort that inappropriate shocks increased the risk of death by 60%. And for each inappropriate shock, this increase was about 40%. Not only inappropriate ICD shocks, appropriate ICD shocks are also linked to mortality in both patients with an implanted ICD device, as well as in those who have a CRT device. So this led to us designing a large randomized clinical trial specifically focusing on reducing inappropriate therapies, the multi-center automatic defibrillation implantation trials, RIT, which stands for Reducing Inappropriate Therapies. And this was the fourth study in the series of the Mediated family of trials that were designed by Dr. Moss and his team here from the University of Rochester. And this was the primary publication of the study. The study had the hypothesis to assess two novel ICD programming strategies. One of them utilized a high rate cutoff with VT therapies above 200 beats per minute. And the other one utilized a longer duration delay to detect and treat ventricular arrhythmia events in patients with dual chamber ICDs or CRTs. And we hypothesized that these novel programming strategies will be associated with a significant reduction in inappropriate therapies. This was a 3-arm study that enrolled primary prevention patients who had sinus treatment enrollment and who were on optimal medical therapy for heart failure. The primary endpoint was inappropriate ICD therapy, and comparing the rate of inappropriate ICD therapies in arm B as compared to arm A, and in arm C as compared to arm A. So it was 2 studies in one, but we did not aim to compare arms B and C to each other. And we had secondary outcomes of all-cause mortality and syncope. We enrolled 1,500 patients, and this was really a global study. We had enrolling sites from the US, Canada, Europe, Israel, and Japan. And the average follow-up was 1.4 years. And this is the programming scheme. I'm not going to go into the details now, but again, arm B was utilizing high rate cutoff, and arm C was utilizing duration delay. And the primary results of Mediated showed that both of these novel programming strategies, both high rate therapy and delayed therapy, was associated with a very significant reduction in inappropriate ICD therapies. Arm B, high rate cutoff, was associated with a 79% reduction of these inappropriate ICD therapies, and MC delay therapy was associated with a 76% reduction. And when we looked at mortality in Mediated, we actually surprisingly found that novel ICD programming utilizing high rate cutoff was also associated with a significant improvement in survival, with a 55% reduction in the risk of death. And we are hypothesizing that this is probably due to avoiding inappropriate and appropriate ICD shocks in this patient population. We also looked at safety endpoint. A visiting fellow, Dr. Rowold from Copenhagen, looked at the rate of syncope in the 3 therapy arms and found no significant differences, suggesting that both of these therapies are safe in patients with a primary prevention ICD. And when we looked at, again, both inappropriate and appropriate ICD therapies, we found a reduction not only in inappropriate ATP and inappropriate shocks, but also a significant reduction in appropriate ATP therapies with novel programming of high rate cutoff or duration delay. So we concluded from Mediated that novel ICD programming with a high rate cutoff or delay therapy is associated with a significant, about 75% reduction in first inappropriate therapy and a 50% reduction in all-cause mortality. And both of these programming arms had favorable safety profiles. Subsequently, we also aim to look at the reduction in inappropriate ICD therapy in Mediated. And as I mentioned, initially we did not plan to compare Mediated arms B and C to each other, but this sub-analysis focused on that specific analysis and looked at the rate of appropriate ICD therapies as well as safety endpoints. And when we directly compared the high rate cutoff and the delayed therapy arms, we actually found that for appropriate ICD therapies above 200 beats per minute, there was a significant reduction and superior effect of arm C delayed therapy over the high rate cutoff. And when we looked at the nature of therapies in these 2 arms, we found that the significant reduction was primarily seen in appropriate ATP therapies for VTs above 200 beats per minute. And for shocks, there was some trend for a reduction, but this did not reach statistical significance. So these findings were further corroborated by Claudio Sugar, and this was just recently published in the Heart Rhythm Journal, again looking at ICD therapies for ventricular arrhythmias above 200 beats per minute. And Claudio's hypothesis was to specifically looking at how we can avoid unnecessary ICD therapies for VTs that would spontaneously terminate with use of a higher rate cutoff or with use of a longer duration delay. And I just want you to focus on this final therapy line here on this relatively complicated figure. And what you see here that the final therapies in arm A, B, and C were very specific. When we looked at the final therapy of an ATP event, it was about 8% in arm arm A, and significantly lower, 2.8% in arm B and 1.4 in arm C. On the other hand, when you are looking at the black boxes here that represent the shock therapies, we did not find a significant difference in the delivered shocks in arms A, B, or C. And these were very similar, 3.5, 3.8, and 3.3%. So again, no difference in the delivered shock therapy among the 3 arms. And this actually suggests that ATP did not prevent by termination or did not increase by acceleration the need for shock therapy in primary prevention ICD patients. So this actually suggests that potentially ATP might not be useful in reducing shocks in a primary prevention ICD population using higher rate cutoffs or longer delays. Probably many of these VTs do not terminate at that point with an ATP only. And there is a randomized clinical trial currently ongoing looking at the role of ATP versus no ATP in this patient population called the PACE-ATP. So another question we often ask as clinicians when we think about utilizing these novel ICD programmings is whether it is safe to monitor slow VTs less than 200 beats per minute in primary prevention ICD patients. So this analysis, again from Mediated, looked at the rate of the monitor therapy events in the study. And as you can see, high rate therapy and delay therapy patients had more monitored VTs, obviously because of their different programming settings. And when I reviewed these events one by one, I actually found that most of the monitored VTs with a heart rate 170 to 199 beats per minute spontaneously terminated well visible on the EGMs. And only a relatively small proportion of them continued under the heart rate cutoff, and only one patient accelerated to a higher rate. When we subsequently looked at the association between monitored VTs and mortality, we actually did not find any linkage which suggests that monitoring these VT events is not only safe, but it also does not increase the patient's risk of death over long-term follow-up. So I'm showing here a table which is actually very elegantly showing other studies utilizing a higher detection rate for VT and VF therapies and their findings beyond Mediated. There were a number of other clinical trials performed, PREPARE, PROVIDE, and RELEVANT, as well as ADVANCE-3. ADVANCE-3 looked at both primary prevention and secondary prevention ICD patients. And all of these studies consistently showed a lower shock delivery rate and either a trend for lower mortality or a significantly lower all-cause mortality in this patient population. Again, showing that these patients benefit from a higher detection cutoff. And not only the detection rate, but also detection delay was linked to lower shock rates or therapy rates in all of these clinical trials, and a trend for or significantly lower all-cause mortality. So based on the findings of these studies, there is an ICD programming recommendation document, which was published initially in 2015. And these are some of the recommendations from that expert consensus document. So 1A recommendation is to require the tachycardia to continue for at least 6 to 12 seconds or 30 intervals before completing detection in primary prevention ICD patients. And another 1A recommendation to program the slow F tachycardia therapy zone between 185 and 200 beats per minute, and discrimination algorithms to distinguish SVT from VT should be programmed on. For VT and VF therapy, the recommendation is to have ATP active at this point. We just simply, need more data on the role of ATP in this patient population. And this ATP should be at least one attempt with at least 8 stimuli and a cycle length of 84 to 88%. It is also a class 1B recommendation to program burst therapy in preference to RAM therapy. And the shock therapies should be programmed on. Actually, it's reasonable to program them on with a 2A indication in all tachyarrhythmia therapy zones, even though we have data that monitoring some of these events might also be a reasonable strategy. And then the last recommendation that it is reasonable to program the initial shock energy to the maximum available energy. And following these recommendations, there was a focused update published as well more recently that provides very specific and very easy to use recommendations for each device manufacturer, since programming parameters might be different somewhat by manufacturers. And this is just one example here of what you would find in this document. And lastly, I just wanted to mention and talk a little bit about implementation of novel programming. The Mediated study was published in 2012, almost 10 years ago. And as you can see here, the implementation of Mediated settings in a real-world population has been relatively low. So in 5 years following the initial publications, we had less than 20% of this registry patients who had their devices programmed according to IMB or IMC. Interestingly, however, when we look at the broader recommendations, not the very specific Mediated recommendations, we find that there is a relatively reasonable percentage of programming these patients with some of these newer strategies. Just as an example, the higher rate cutoff was programmed in over 70% of the patients with an implanted ICD. So I think these are altogether very promising. And in conclusion, I just wanted to say that high rate cutoff and delayed therapy ICD programming has been shown in multiple clinical trials to significantly reduce the rate of both inappropriate and appropriate ICD therapies. And these novel programming strategies are associated with a better survival. These ICD programming strategies also have a favorable safety profile. And I showed you data that monitoring slow VTs in primary prevention ICD patients is reasonable, and it does not carry additional risk of syncope or mortality. And ICD programming with high rate cutoff or longer delays should be considered in all primary prevention ICD patients. And I will stop there, and we will be taking questions, I believe, at the end of the session.
So thank you, Dr. Kutifa, for this thorough and interesting talk. I think we will leave the questions to the end of the lectures. Now I would like to invite Dr. Gurjit Singh from the Henry Ford Heart and Vascular Institute, Henry Ford Hospital, Detroit, Michigan, to give the next talk about interaction between mobile devices, pacemakers, and defibrillators.
All right. Thank you, Dr. Crystal, and thank you, co-chairs, Dr. Farkash and Suzette, for letting me talk about this simple but important topic. Am I audible?
Yes, you are, and you can go to presentation.
And you can see my screens as well? Okay. So again, with further ado, I have no financial disclosures, and my talk is not the conventional EP, so I'm not talking about any ablation strategies or anything in particular, no nerve ablation, but some of you may know by now that I did get onto the nerves of one of the biggest companies on the planet with our publications on the iPhone 12 and the interactions between a defibrillator. So as such, the reason for my talk. So my talk will be for the next 10-15 minutes. We're talking about some basic concepts. I'll take you back to your physics courses about radio frequency energy, phones, and the interaction. So magnetism, the magnetic flux is measured in units called Tesla. 1 Tesla is equal to 10,000 Gauss. and 1 millitesla is 10 Gauss. So most of our discussions today will be using the units as milliteslas. But just to give a perspective, the Earth has a magnetic field being in big iron core, and the Earth's magnetic field is barely a 0.25 Gauss, 0.65 Gauss. It's a very, very small magnetic field. And it is very well known, just like for any electromagnetic radiation, the intensity of the radiation falls off as the inverse square law. For magnetism, there is some data that it falls off with the cube of the distance. So as you go away from the source, the magnetic effect goes down. So this concept will come very handy at the end of the talk. Electromagnetic interference basically means interference caused by one electrical or electronic device to another electric device due to the electromagnetic field. And in the world of cardiac implantable devices, it all depends on the distance from the source, the design of the ICDs or the pacemakers, the shielding, the programming parameters, as well as various filters. So briefly, an ICD shown here is a big device. It has a capacitor which stores a charge. There's a battery. There's a brain of the device which has the microprocessor with all those signals. And then there are a couple of other filters and high voltage. And this is a schematic showing you that for a defibrillator, the charge is delivered. The high voltage capacitor is first charged to a transformer. So the defibrillator doesn't store 1,000 volts of electricity. At the time of delivery, when the defibrillator is charging, that 3 volts of DC current is changed into the 1,000 volts. And here is an example of an ICD I just opened up yesterday, showing you, this is a Boston Scientific ICD, and showing you various components. On the left-hand side of the screen is the big capacitor for the ICD. This is the battery. This is the brains of the defibrillator. And this circuit here includes all those pacing sensing circuits and various sensors. And here is the telemetry coil through which we interact with the devices these days, either via Bluetooth or the radio active radio coils. And we all know the reason we are talking about this is due to these magnets. We all know we have clinical magnets, these donut magnets used to interact with pacemakers or devices, usually to determine battery life, to turn off the therapies when patients are going for surgeries or for MRI, and to pace asynchronously. So let's talk about sensors. So how does these magnets interact with these devices? So what is there in these devices which tells the device to do certain behavior? So that goes on to talk about sensors. So in the past, the devices, ICDs and pacemakers, have these switches called a reed switch. It's a very simple concept. It's like an inert glass tube which has 2 metal plates. And when these 2 metal plates come in contact with a magnetic field, they either close or they open up, and thus acting as a switch. Shown in this video here, as you can see, the reed switch is coming in contact with the magnetic field and the switch is being closed. So when a magnet comes close to an ICD, it turns the switch on and it turns a sensing function. So for a pacemaker or ICD, what exactly this reed switch does is the sensing circuit is bypassed. So a pacemaker is not going to see any cardiac activity and it starts taking the asynchronous. Or a defibrillator, the VTVF sensing circuit is turned off and the ICD therapies are inhibited. So you are not actually turning off the device by itself, but you're just turning the sensing circuit off. In a defibrillator, the pacing will not be inhibited. Typically, there is data that these reed switches usually usually get closed whenever the magnetic field is of the strength of around 0.9 millitesla, and they open up at 0.7 millitesla. And it used to be a notion that the reed switch will always close in a magnetic field. So let's say you take a patient with a pacemaker or defibrillator, you bring them to a magnetic environment, and you will think the reed switch will close and patient will be asynchronously paced all the time. But then there were studies in the past, they showed actually based on the magnetic field strength. So if you are in a less than 50 millitesla environment, the reed switch will behave the way it should. It will close and the pacemaker will pace asynchronously. But in a magnetic environment, such as a 3 Tesla MRI scanner, these reed switches actually get pulled away. So there are opposite magnetic fields. The reed switch will open and the asynchronous pacing will not happen. And the electromagnetic effect from the MRI can cause an asystole in a patient. So there was problems with these reed switches in the past. In a pacemaker shown here, I'm showing you, this is how a reed switch looks like. So we don't have this technology anymore, and this technology is changed to what we call Hall sensors and GMR. The Hall sensor was developed by Edwin Herbert. This is in 1800s from Johns Hopkins. And what he did basically, he observed a very interesting concept shown in this video here I'm going to play. What you see here is a tiny metallic plate connected to a battery, and you turn the battery on and you see the movement of charge. The electrons are going through this device, through this plate in one direction. Now, when you bring a magnet of enough strength close to this metallic plate, what does that magnet do is it pulls the electrons towards one direction. So thereby, these electrons will start accumulating on one side of the plate. So one side of the plate will be negatively charged, the other will be positive, thus creating an electric field. And you can measure that electric field in a voltage, and that is called a Hall voltage. So this metallic plate basically acts as a switch when you bring in a magnetic field, okay? Something similar, what we call a giant magnetoresistance sensor. So this technology is a very common technologies in various of things. What basically this is, there are two magnetic material or magnetic plates sandwiched between a non-magnetic material, which is usually copper. And what this plate does is, when in the absence of an external field, these two magnetic plates have opposite magnetic field, and the resistance to electricity is low. But when you bring an electric magnetic field close to this thing, all the magnetism goes in one direction, and the middle plate starts having electrical flow. So there's a resistance change, and that resistance can be transformed into an electrical switch. So this is a MRI, or sort of electron microscope of these switches. We're talking about, this is a nanometers technology. It's a very, very small, thin technology. Abbott St. Jude uses GMR sensors. Medtronic Biotronic uses Hall sensors. Again, these are very stable sensors, low power consumption. So that's why after 2006, St. Jude started using GMR sensors. And if you bring a magnet close to a St. Jude device, it will actually record a magnet response, and this will be stored in the device memory. So there is a couple of just like ISO standards. So there are some standard committees, and this is the Academy for Advanced Medical Instrumentation, AAMI, which actually determines or creates these guidelines or these parameters, or how safe the magnet should be. So many years ago, this 10 Gauss limit was implemented voluntary, that anything above 10 Gauss will turn on the ICDs, read switches, and so on and so forth. And this is their website. So let's talk about interactions. So what happens when pacemakers or defibrillators comes in contact with cell phones or magnets? So there is a theoretical risk of what we call asynchronous pacing. So when your reed switch is closed, if you start asynchronous pacing in a patient who has an underlying rhythm, you can have a competitive pacing going on, and there's a very chance that you can create an RMT phenomena. So this is a paper from New England Journal of Medicine from 1967, which showed a patient goes into VF due to competitive pacing. We don't see this very clinically often, but there are case reports of RMT phenomena with asynchronous pacing. Moving forward, interestingly, so everything on a daily basis can interact with ICD. So this is an example showing you a device called a zapper, which is actually used to remove parasites, which I didn't know. So you hold this device in your hands, and it will create electrical field and can take the parasites out of the body. So this is an example showing a patient who's pacemaker dependent, who's using this device, and he basically becomes apostolic due to these interactions. There are case reports of microwaves interacting with pacemakers. All these are older data. There are cases of airport surveillance, electronic gates doing that. So how do phones interact with our devices? So we have to go back to our electromagnetic spectrum. As we all know, this is all, the radio waves are on the lower end of the spectrum. So longer wavelength has low frequency and low energy, and then the gamma rays are the high frequency. And usually the typically TV, radios, and cellular things operate in the radio wave frequency zone, which is on the lower end. And the FCC owns this zone, which that's how you do your transmission on your radios. And then now we are going to the higher the energy of the 5G. So how does a cell phone work? The cell phone, when you talk cell phone A, your voice is converted to the radio waves, which are transferred to a cell phone tower. The cell phone tower checks your number, makes sure you're the right person, and then that cell phone tower will send a radio frequency back to the cell phone B, and which the data will be converted to your voice. So that's pretty basic principle how the cell phone works, but they use radio waves. As shown here on this spectrum, now we're talking about 4G and 5G. The 5G is using microwave energy, so our frequencies are increasing in intensity as we move forward and into the cellular world. So a lot of data on cell phone. This is the data from 1990s. There were a lot of case reports of cell phone causing pacemaker inhibition and so on and so forth. Here, an example shown in 1990s, a patient with pacemaker dependent, and they bring the cell phone, and back then was GSM technology, and you can see is oversensing causing inhibition. They have shown, there's various of the studies, and the third with the 3G phones were found to be safe. They also did studies on patients with ICDs, and they also found the 3G phones were safe with ICDs as well. But there are cases of pacemaker inhibition and asystole with older generation of phones. And this is a famous paper from New England Journal of Medicine from 1997, where they took 980 patients. They used 1 analog phone and 4 cellular phones. This is again GSM technology. A lot of patients with pacemakers and only pacemakers, and they found that almost 20 to 30% interference was recorded, in terms of inhibition or some oversensing. Moving forward, there are some other data from other countries using different kind of phones showing something similar of the range of 5 to 10% interference up to a distance of 10 centimeters from the pacemaker or the ICD. And here is showing you that this patient has ventricular triggering. There is inhibition from these cell phones. And this is a nice meta-analysis from 2006, which compared all these studies and shows that in the early years in 1990s, the interaction was almost upward of 50%, but has gone down over the years. So how did it get better? So some smart person discovered that some ICDs and pacemakers have these filters called a ceramic feed-through filter. And these filters were actually doing its good job in decoupling or in storing those electromagnetic interactions or radio frequency from the phones, and thus preventing the interaction. So now these ceramic feed-through filters are pretty standard in all our current generations of ICDs and pacemakers. So that was the fix for the radio frequency issue with the cell phones. So what about magnets now? Now, as I showed you before, these are the clinical magnets, but magnets are everywhere, right? And when you're home, now you look at these neodymium magnets. So these are very strong, small magnets, very easy to produce, easily available. You see them on every day, in your kids' toys, in your jewelry, in your clothes. I had an example showing you a patient actually had multiple ICD replacement because he kept having these noise on his ICD and mode switches, and they couldn't figure it out. He had 2 defibrillator changeouts. In turn out to be, he was wearing a hoodie which has this cap connected to the body of the shirt using a magnetic clip. So finally they figured that out. This magnet was causing his ICD noise, and he didn't have any subsequent changeouts. So magnets are everywhere. They have tested neodymium magnets. This is an elegant study, looked at various kinds of magnets and looking at interaction, how strong. Shown here is these tiny magnets coupled together, and this is an iron powder and shows how the magnetic field surrounds these magnets. And you can have hotspots as shown here. So what they found is up till 3 centimeter distance, these devices can interact and turn off a defibrillator or a pacemaker. So that's very important to know that these are very strong magnets. Coming to now, moving fast forward to in the last 2 years, there are a couple of studies or papers showing various interactions. So this is a interesting paper from a BI from Dr. Tedrow showing a patient who was carrying a vaping device in his pocket and had magnetic reversion of his defibrillator. And these vaping devices have, these the atomizer, this battery, they're connected with each other through a magnet connection. So that magnet was causing the problem in this patient. Last year, Philip Lacour did this elegant study using iPhone 6 and Apple Watch Series 1, and they took a lot of patients and tested interaction of these phones and Apple Watch with patients with these devices. So they have patients from all different variety of companies, from Medtronic, from Abbott, from Boston Biotronic. There was one Micro as well in this study. And what they basically did was they took 148 patients. and they brought the iPhone close to these devices, and they turned the phone on. They looked at for interaction when calling the patient, calling the phone, when the phone turning off, and during conversation. So what they found is that there was 14% incidence of EMI with the telemetry, which means there was loss of event markers, there was inappropriate markings. So there was loss of interaction with telemetry, but a clinical interaction was only seen in one patient, in a patient with Medtronic pacemaker, who was an AFib and has appropriately mode switched. When they brought the iPhone 6 close to the pacemaker and called the phone, what they discovered that the patient certainly starts pacing fast in his ventricle. And what they discovered that the phone ringing or the calling the phone actually turned the mode switch off and put the patient back into the DVD mode. That was the only one clinical interaction that recorded with the pacemaker. Here is an example of loss of telemetry or different annotations, which was upward of 14% incident. So they came up with this conclusion that the incidence of EMIs between iPhone 6 and CIEDs was low. Apple Watch did not cause any EMIs. iPhone 6 frequently caused interferences with telemetry, and neither the iPhone 6 or Apple Watch caused any magnet effect on the devices. So moving forward, so this last December and January, we discovered this interaction. One of my fellows, he got an iPhone 12, and as we were talking about it, we discovered that the iPhone 12 comes with an inbuilt magnet for rapid charging. So we tested this interaction on a patient within a Medtronic BiVACD cobalt model. Shown here is his chest X-ray, and what we discovered when we brought this phone close to the body. Here is an example showing you the phone sitting on a patient's dressing, and the therapies were suspended. And when we moved this phone all around the profile of the device, this suspension was there. And as we moved the phone away, the device reverted back to its normal behavior. So this led to our publication, a letter to the Heart Rhythm Journal, which got a lot of attention, as you can see here, throughout the world, with people calling it pacemaker inhibition and so on and so forth. Good talks and some were bad ones. And then because of this, the Apple issued a new warning to keep the phone 6 inches away. And this is their support page, which actually came with a new warning saying basically that the Apple iPhone 12 has more magnets, so please be careful. So what exactly is this interaction? Is basically called an Apple MagSafe. So what they did is they came up with this fast charging technology, upward of 15 watts. So you can rapidly charge your phones using the MagSafe technology. What it does, it is basically a magnetometer with an NFC reader and a couple of shields and a ring of 18 magnets. So what I'm going to show you is how this QI charging happens. So this is what we call a wireless power transfer. Up to a distance of 4 centimeters, you can transfer power from one device to another without using any wires. It's called the technology called a resonance inductive coupling. Inductive coupling, we all know as like in a transformer, you have a primary coil, you bring in electricity, and through the magnetic flux, you can change the electricity in terms of its type and strength. In a device without these wires, what you do is you bring an electrical charge on a coil, and that coil creates a magnetic field. That magnetic field is sensed by an external coil, and that will be transferred into the data. Shown here is a usual QI charging device. You bring a charge here into this device. A magnetic field is created, which will be transferred into the phone, and the phone will be charged. So basically, you need a charging coil. So what Apple did basically, they said, why don't we put a magnet around this charging coil, so when you put a phone on this charger, the phone will stay together, and you can rapidly push in power. And this is a slide showing you a CT scan of an iPhone, and this real things here is the magnet. So if you open up an iPhone 12, this is how it's going to look like. There are 18 magnets around this charging coil on the back of the phone, which causes the rapid charging. Okay, and this is a test done by myself. I bought a Gauss meter and tested this magnetic field strength, and to my surprise, I was able to get a reading of 42 millitesla, which is 420 Gauss on the back of the phone. This is 42 times the limit of 10 Gauss as set by the FDA and FCC. I also tested an Apple Watch, and you can see here the magnetic strength is upward of 1230 Gauss, so 120 times higher than what is required from ICDs and pacers. So other papers have come out. This is a paper showing a lady with ARVC and VT had a secondary prevention ICD, and she was sleeping with her Apple Watch on her chest overnight, and her device started beeping. So they tested and found that this Apple Watch wristband contained magnets. So they tested this interaction on an ex vivo device and found that a Fitbit can deactivate an ICD up to a distance of 2.4 centimeter, an Apple Watch wristband can 2 centimeter, a regular clinical donut magnet can interact up to a distance of 8 centimeter. This is the recent publication from Europe. Again, they did an ex vivo testing of various pacemakers and defibrillators from Medtronic, Abbott Biotronic, and they were able to turn off the defibrillator or cause pacing and asynchronous pacing in a pacemaker from a distance of 2 centimeters. So with that, the recommendations have already been there. We all know that the 6-inch recommendation was there. And that's what we are telling our patients, that please keep your phone 6 inches away or any electronic device. Inform patients at new implants, revisions, replacements, and device follow-up. I think what we need to do is to educate the community and then to create scared. Future changes might happen, which we will know in the near future. Thank you.
Thank you, Dr. Singh. Very informative session.
Okay. Dr. Suzette Turner is.
Hi, do you want to pass it to me?
Yes, please. Mr.
Hi, it's Eugene Crystal replacing Suzette. We have a little technical issue. It's my pleasure to introduce Callum Rathband, speaking about palliative care and cardiac implantable electronic devices, which is an emergent topic in all of our patients, and we're much more aware nowadays on the importance of appropriate palliative care for the patient's quality of life and health resources. Callum, please.
Good afternoon. Can you confirm you can hear me just fine? Perfect. Okay, good afternoon. As you heard, I'm Callum Redpath from Ottawa. I'm grateful for the invitation to be able to speak to you today. And I shall just speak for 10 or 12 minutes on palliative care and CIEDs. I do not have any disclosures to report, and I think it'd be useful for all of us just to set some definitions. So what exactly do we mean when we talk about palliative care? And I believe this is important. Again, I'm not a palliative care physician, I'm a cardiac electrophysiologist, but I do have the benefit of working closely with Dr. Downer and the Canadian Society of Palliative Care Physicians. So palliative care is an approach that aims to reduce suffering and improve quality of life. And primarily, this relates to pain and symptom management, or really, as I would think of it as a reductionist, as a cardiologist, is it the reduction of pain and the improvement or amelioration of symptoms. And that can be achieved in a variety of ways. The key concept is symptom reduction. And what do we mean by cardiac implanted electronic devices? Well, we're primarily thinking of pacemakers, and as I'm sure many of the watchers or listeners or attendees today are aware, but in case you're not, pacemakers are primarily indicated for symptomatic bradycardia or symptomatic heart failure. That would be resynchronization pacing, often given CRT designation. And of course, pacemakers don't prolong life other than that they correct the underlying medical problem, which is bradycardia. And we know that pacemakers will merely return patients back to their age and standardized mortality as if they did not have the underlying problem, which is heart block. And we know that in patients that do not receive pacemakers for a symptomatic heart block, for example, in the developing world, they will have a 40 to 50% 5-year survival. And I think that's important. We'll discuss why I'm raising this point later. For defibrillators, defibrillators are high voltage implantable devices placed in order to protect against sudden death. They may have a pacemaker function, they may have a resynchronization function, but primarily these devices intervene in the presence of tachycardia. So we often refer to these as tachytherapy devices. And then the other emerging technology, or at least the technology has been around for a while, but the non-pulsatile left ventricular assist devices to provide mechanical circulatory support are expensive implanted devices which augment cardiac output sufficient to ameliorate symptoms of heart failure and low blood pressure. So, palliative care in Canada, what do our patients want? And this is primarily driven by the patients. And the vast majority of Canadians consistently tell the government, but this is government data, that they would prefer to die at home. The reality is the majority of Canadians die in hospital. And indeed, palliative care, really, I have learned, is a bit of a Cinderella specialty, and I mean in absolutely no disrespect. This is a service that is often lauded and is often desired, but has not really hit mainstream. It's not a major part of hospital service. And yet, as I've just told you, the majority of Canadians die in hospital. And only about 15% of Canadians have access to palliative care at home. And when that service is provided, these patients are more likely to die at home, i.e. congruent with their desire to die at home. And they actually reduce the use of the healthcare system, at least as far as unscheduled emergency room visits and ICU visits and stays. But yes, 15% of Canadians have access to this, but who receives palliative care? It's not patients with cardiac implantable electrical devices. These are younger patients primarily suffering from cancer. And so in recent years, there's been an expansion of palliative care into the heart failure paradigm, which makes perfect sense to me. And indeed, we in our centre in Ottawa, and I know in other places across Canada, palliative care coming into cardiology is really helping us manage our patients better, whether that be preparing them for the end of life, or indeed managing their end of life. So what does that mean for Canadians with CIEDs? Well, approximately 120,000 Canadians have these. So this is not an insignificant problem. And if you look at the most recent government data published just a few months ago, we're implanting essentially 23,000 de novo devices a year. So on top of the 120,000, obviously, these patients still die, and that's important to remember when we're talking about palliative care, that although these devices delay death, they do not prevent death. And so we have to be aware that these patients will still go on to die, and we must help them die in the most acceptable way possible, congruent with their treatment goals. And in actual fact, as I said earlier, for our elderly patients who in the main receive cardiac implantable electrical devices, more than 80% actually die in care facilities, whether it be a hospital, a long-term care facility, or indeed a hospice, although that is a very small number, a little bit like LVADs, but is emerging and is increasing rapidly. Now, primarily, where is it that CIED management can intersect with end-of-life care? And primarily in an active sense. So I don't mean managing, discussing, preparing, and educating. I mean where the rubber meets the road. And it's because at least 20% of patients with ICDs, even in the presence of the majority of them, have do not resuscitate orders. And remember, most of these patients are dying in hospitals in Canada. 20% of these patients are expected to still be receiving unwanted. So I don't mean necessarily in terms of an arrhythmia, appropriate or inappropriate, but unwanted defibrillator shocks. These are painful, These are painful for patients who are already very vulnerable, and of course is distressing both for the patients, but also their medical attendants, and of course their family members if they are present. Now, I want to address the elephant in the room very quickly. Medical assistance in dying is not the same as deactivating cardiac implanted devices, okay? Just in the same as cardiac implanted electrode device deactivation is not the same as medical assistance in dying. Now, I only have 10 or 12 minutes to talk. I'm not going to go through the ethical or the legal or the moral, or even the medical, in my opinion, difference in this. With Dr. Downer, we are leading an attempt to try and codify device deactivation for the benefit of patients and those of us working in palliative care and in CIED management. But predominantly when it comes to pacemakers, as I referred to earlier, pacemakers do not prolong life. There is actually, again, only observational data that in patients in the terminal trajectory of their life, i.e. actively dying, the presence or not of a pacemaker and the presence of a pacemaker, active or inactive, made no difference to the median time to death. So pacemakers do not prolong life in the absence of heart block. They merely return patients with pacemakers back to their age and standardized mortality in the presence of heart block. So they basically, a little bit like an old advertising slogan, they do exactly what they say in the tin. They treat symptomatic bradycardia. Indeed, as we all know, many thousands of patients with pacemakers die every year. In explanted devices, we see either tachycardia or continued pacing activity long after it was recorded that the absence of vital signs. So we know that patients will die with pacemakers, and we know that patients in the presence of pacemakers, they're in the terminal part of their life, will not live longer than otherwise. And so that's an important myth to debunk. Secondary, for defibrillators. Defibrillators may well, in the sense of a metabolic or respiratory acidosis induced during MAID, may well, it would be expected to have ventricular arrhythmia. And so it is important that at the time of the patient's choosing, that the tachytherapies be deactivated in a manner that's been discussed with them in advance. Now, many patients, having interacted with both American and Canadian physicians delivering MAID, will actually choose to keep the therapies active right until the point of the MAID delivery. And what that means is there's one less thing for them to worry about, and that they're not going to die in a sudden, unexpected way, or to receive to die in a sudden, unexpected way prior to the planned delivery of medical assistance in dying. And at that stage, if the patient wishes to have tachytherapies deactivated, then the magnet to be placed for a short period seems an eminently reasonable way to achieve this. The last would be of these mechanical support devices, so left ventricular assists. And so there has been one paper from Boothroyd in 2016 from Canada, 2014 from Canada, demonstrating that that with the presence of palliative care in LVAD providing centres, that deactivating these mechanical support devices actually does result in rapid hypotension and death in the setting of the pre-existing condition. And so therefore, the presence of palliative care and the deactivation of the mechanical support, can be an adjunct. But of course, if the patient chooses MAID, there's actually no compulsion to turn off or turn down the LVAD, because the delivery of MAID is irrelevant to the presence of the LVAD, and that the overwhelming respiratory or metabolic acidosis, which is induced during MAID, has no difference in time to death. So when, as mentioned earlier, I have a document on my desk, and I'm working on it this morning when I was listening to the talks. Here we have the sum total of the randomized control trial, the gold standard evidence for how we should manage implantable devices in patients requesting palliative care. So as there's no data, what are we doing? So the method we've used is we've already surveyed all CIED practitioners through the Canadian Heart Rhythm Society. We are about to survey all the palliative care clinicians. Through the university, we have performed a literature review. I've read all 389 papers. We have a modified Delphi process of 50 statements that must be agreed by all of the primary writing group. That's 22 people throughout our communities, both in CIED and electrophysiology and in the palliative care realm. There's a paper in review with CJC, which is a clinical it's with relating to device management and during medical assistance in dying. We are going to produce a deactivation clinical practice update, which I hope will be in print later this year, and it will provide deactivation logistics and SOPs. And I'm very pleased to say that every major CIED manufacturer we've had meetings with them, and we have a plan to bridge the gap so that patients can have flexibility in the timing and in the type of deactivation they seek. And remember that patient autonomy trumps what we believe is important for the patients. And so we have to have that liaison between the patients, industry, and the practitioners who are looking after these patients. And so here are the first principles upon which we've based this document, which I said should be available later this year. I took great pains to reaffirm that in pacemakers or synchronization, these devices are primarily implanted to reduce symptoms, and therefore to deactivate them would be incongruent with the principles of palliative care, which is to reduce symptoms. Now, of course, patient primacy and autonomy must come first, but we have to counsel our patients as to what to expect. Anecdotally, I've done this 7 times. And in the 6 of the 7 patients who were truly dependent, that is, they were symptomatic at VVI 40 with little in the way of intrinsic cardiac rhythm, every patient requested the device be reactivated because they were sufficiently symptomatic when we turned down pacing. So pacemakers organization, they alleviate symptoms, they don't prolong life. And so in principle, then there's no further action required in palliative care. But we must individualize care and respect autonomy, and on an individual basis, patients absolutely have the right to withdraw consent for ongoing treatment. For ICDs or tachytherapies, then of course we should have that discussion, and there could be programmed. We heard earlier from Dr. Katifa, the modern 2019 paper with Stiles gives very clear suggestions for empirical programming to reduce shock therapies, which are the symptom giving therapies from ICDs. We must screen in advance with the widespread adoption of electronic medical records. There are systems, and we're going to suggest some that you may wish to consider in your own centres, whereby when you screen patients for DNR orders, where you admit them under palliative care, when you change their treatment goals in that system, then the presence of a CIED can be flagged, and then you can have that discussion in advance as to how patients want us to manage their CIEDs. Obviously, the simplest and the most common request, but it doesn't appear to be requested either early enough or frequently enough as far as the data is concerned, is that tachytherapies can be deactivated. Whether you deactivate only shocks or shocks and ATP is for something to be discussed between the CIED clinician and the patient. There are arguments for and against both at the time, and it should be performed at the time of patient's choosing. With left ventricular assist devices, because patient death has been associated with only a short duration after these devices are deactivated, then really palliative care must be present, or cardiology and palliative care. And we already have in 2015, Dr. Downer chaired that, hence him and I linking together to produce this document specifically with CIEDs, have guidelines in the withdrawal of life-sustaining therapy, and LVAD certainly would fall into that category. So although resuscitation is not the same as ICD therapy, deactivation of ICD therapy should be the norm. We do discuss resuscitation with our patients already in hospitals, and the vast majority of Canadians are dying in hospitals, but it currently is not. And we need to find ways, and we're going to provide suggestions to systematically discuss and deal with this problem in advance so that we can care for our patients better. And I know from the survey results, which I have not published and referred to today deliberately, that there are a widespread spectrum of opinions on this disorder. CIED deactivation is here to stay because it's part of clinician professionalism. It's going to be driven by our patients. We must respect autonomy. We must think of these patients as our family members who have devices, and if their treatment goals change, we need to reflect that in their programming. We have to act in their best interests. We must communicate and cooperate with the patients, their families, and each other much more effectively. And if, as an individual practitioner, we are uncomfortable educating or performing our patients' wishes, then we must make an effective referral. At that point, I'd like to stop in the interest of time and be happy to answer any questions.
Thank you very much. Thank you, Dr. Redpath, for this wonderful and sensitive talk. I invite all the speakers for a short, very short discussion because we are behind time. And I invite the audience to participate and send questions. I'll start with Dr. Kutifa. Okay. So what do we know about the mechanism of increased mortality in patients with inappropriate shock?
Yeah, so, that's actually an excellent question. As we know, some studies suggest that the underlying arrhythmia might be actually responsible for the increased mortality, such as atrial fibrillation that we see in many of these patients, that could represent the kind of advanced stage of heart failure in this patient population. There are also some other, studies and speculations as well, suggesting that shock itself might have a deleterious effect. So I think this is, very much of kind of a complicated question that many of us studied, but it's still a little bit unknown. And we did one study actually, looking at both inappropriate ATPs and shocks, and suggested that maybe not the shock itself, but the underlying arrhythmia might be responsible for the increased mortality in these patients.
As you showed, the 2019 consensus statement on the optimal ICD programming gives the options of a delayed therapy approach or the high rate therapy approach in primary prevention patients, at least the Boston Scientific devices. Which approach do you prefer?
Yeah, so, just based on some of the data I showed today, I think the combination of both might be the most beneficial in patients. With high rate cutoff, we have seen, very significant reductions in inappropriate therapies, as well as with the delayed therapy. But if you add a delayed therapy or VT detection to the high rate cutoff, you will be able to further reduce not only inappropriate therapies, but also unnecessary appropriate therapies for VTs that will self-terminate if you wait a little bit longer. So I would say the combination of both, but of course, I also wanted to mention that this has to be individualized to your patient's needs. So, maybe in some patients, especially in those who had a history of syncope and, had, especially the ones who had prior VTs, I think this will be a little bit different. For primary prevention ICDs, I would be just aggressively using both the high rate cutoff and the duration delay.
Suzette, do you have more questions?
Not for Dr. Kutifa, for Dr. Singh. Someone had mentioned earlier if there were any concerns about induction ovens as well in terms of magnetic influence on devices.
Yeah, I mean, those were in the past, as I mentioned, induction ovens or microwaves, they all use the radio frequency energy. That is not seen currently because of the newer ceramic filters. So I don't think that is a available, has been seen in the recent past. I mean, the data I showed you was all in 1990s, but nothing on the newer devices.
And one more question to follow up. What about hearing aids? They also have the hearing aid assistive.
Correct. So hearing aids, your speakers, your AirPods, your headphones, all contain magnets. So again, the recommendation is to keep all these devices 6 inches away. Now, I think the key message from all this testing and everything is, as I showed you, the magnetic strength falls off with the distance. So we have, and same as FDA has done some bench testing, that the magnetic fields, for example, from an iPhone 12, within a centimeter or so, it falls up tremendously. At the surface, I showed you is 420 gauss, but within a centimeter distance, it goes down to under 10 gauss. And I have tested AirPods. AirPods has all the way up to like 260 gauss of strength. So I think the goal is, regardless of what device, what phone case you have, we need to tell our patients to keep things away, 6 inches away from these devices.
Okay, thank you.
I have one more question to Dr. Singh. We had this problem in our society, in our association. Do you think that National Heart Associations and working groups, or even Ministry of Health in different countries, should give a formal statement regarding the possible danger of the interaction between the new generation iPhones and maybe the fitness tracker wristbands with the ICD? Or do you think that we should leave it to the individual pacemaker clinics and personal consultation, such as individualized testing of patients and their iPhones or something like this?
Yeah, great question. So I think individual testing is going to be tough regardless, because there are so many third parties devices, right? So, I have seen patients with phones who have magnetic cases, like the whole case is a magnet. So it'll be very hard to test every single patient. And I think as more data comes out, FDA, Heart Rhythm Society, I'm working with all these and the AAMI. So there will be a statement coming out shortly, hopefully in the near future. I'm finishing up a clinical study with all these devices and different phones now. But I think at the end, the message will likely be that please keep these devices 6 inches away, which seems to be a very good safety distance. I think that's what needs to happen. Like, there's more community teaching at individual level. Every device clinic, every EPs or nurses that needs to do that. But that's what AHA is saying. I believe HRS will come up with the same message.
There is one more question from the audience. Are there any data for non-Medtronic devices regarding
we have tested Abbott, we have tested Boston devices, and as I showed you, the paper from Europe also tested Abbott and Boston devices. Ex vivo, they have shown interaction. My clinical study is ongoing, where we are testing with patients clinically, where we're going to bring the phones close to the device, keep them in the pocket, and measure some distance. So hopefully we'll have some clinical data within the next month or so. But we have seen interactions with other companies as well.
Right. I have one more question to Dr. Redpath. The issue of palliative care and the devices is a sensitive but a very important issue in our daily practice. I would like to ask you specifically about the difference between pacemakers and defibrillators in patients nearing the end of life. In my country, there is a special regulation for the rights of terminally ill patients with prognosis of less than 6 months. And there is a difference between cyclic therapy, such as dialysis, reloading inotropes, and between a continuous therapy, such as mechanical ventilation. ICD is considered cyclic therapy, and therapies are allowed to be disabled in the patient if the patient wishes to do so. However, pacemakers are considered continuous therapy, and we are not allowed to deactivate them. It is interpreted as assisted dying. What do you think about this difference between pacemakers and ICDs in this regard?
So, as I understand it, it's a regulatory authority's opinion on or classification of CIEDs, differentiating between tachy and bradytherapy. So I think, number one, obviously, I don't necessarily think that the type of device is the most important issue. It's the patient's right to self-determination. So that's the first response I would have. The second is, I think, in my opinion, a fundamental misunderstanding of pacemaker versus the defibrillator therapy. This is a personal opinion, and that opinion is that pacemakers will only intervene under certain circumstances. So a lower rate limit of 1,000 milliseconds is 60 beats per minute, and so therefore they can be programmed so that they are intermittent, and approximately 50% of patients who are designated with symptomatic bradycardia and have complete heart block do have an intrinsic cardiac rhythm at VVI 40. We know that if you just rapidly turn devices off, that the RR interval is inversely proportional to the recovery of any automatic tissue, whether it be the side atrial or the AV node. And so if you decrement down, that's turn down the lower rate limit, you can induce, or you can see the intrinsic cardiac activity recover. We also know that in patients who are deemed to have no cardiac output at 40 beats per minute lower rate limit, that you can induce cardiac activity with the infusion of isoprenolone. So I think that personally, I would wish the paradigm of care for a patient should put the patients at the front and not the defibrillator or the type of device at the front. And the second thing is that as far as you know, the legal authority of your regulatory businesses, of course, I wouldn't dream of impugning. Each sovereign nation is completely at liberty to set its own rules according to the laws, and I would not wish to encourage individual practitioners to contravene those laws. But I think that you know, most that in modern nations, patients have the right to self-determination, and that for regulatory authorities to limit their abilities to self-determination, you know, can and should be challenged by patients.
Thank you.
Thank you.
Suzette, would you like to?
No, I think we're running on time here. So thank you very much to the panelists for a lovely presentation, and so much more to ponder and discuss further. Thank you very much. Dr. Crystal?
Thank you, guys. We will declare a quick 3 minutes break before moving to remote monitoring. Thank you. Hi, everyone. Hope you hear me. We're starting our session named Remote Monitoring in Cardiac Devices, and I'm pleased to introduce Larry Stearns, who is electrophysiologist from Victoria and the president of CHRS, and Adrian Baranchuk, who is a professor of medicine and a very close friend from Kingston University, from Queen's University, Kingston. Please, guys.
Thank you, Dr. Crystal. It is a real pleasure to me to co-chair this session with my colleague and friend, Larry Stearns, who is currently serving as president of our society, the Canadian Heart Rhythm Society. And we are delighted to introduce two phenomenal speakers. And unfortunately, Niraj Verma, a well-known electrophysiologist and researcher in the area of cardiac devices, cannot be present with us, but he has submitted his presentation, and I am happy to introduce him for the first talk, Remote Device Monitoring. Please go ahead. We can see the slide. We need the sound now. Larry, I invite you to say some words until we have it, or we're
Just
ready.
waiting for the technical stuff.
There.
Do we have any audio?
I thank Dr. Eugene Crystal and the organizers of the International Arrhythmia School for the opportunity to present here current aspects and future developments in remote device monitoring. So the management of patients receiving cardiac implantable electronic devices really reaches for the goals of improved outcomes related to device function, and also increasingly monitoring functions which might permit disease modification, so disease-related outcomes. The challenges are the volume of patients that we have to manage and accommodating them, scheduling them with limited clinical resources. Patient adherence to follow-up schedules is always a challenge, and clinic workflow to maximize efficiency is something that is always adjudicated on the basis of the technologies that are used and the available resources. However, generally the complaint is that they are all constrained. What are the potential solutions? Well, remote monitoring, remote patient management has been advocated for many years as a potential solution for CIED management, patients who've received CIEDs. There is remote follow-up, where a patient has a transmitter at home and merely replaces appointment-based in-clinic checks with appointment-based home checks. So that is remote follow-up. Importantly, this still follows a regular appointment-based schedule. There is remote monitoring, which reduces the need for in-clinic follow-up. That is continuous remote monitoring with current devices that permit daily surveillance of device function. And then, of course, there is remote monitoring only. And this is a newer development, a newer aspect, really reflecting the evolution in technologies. So the idea is, as seen in this cartoon in the top and in the bottom right-hand corner, to monitor a large population but be able to readily identify those patients that require in-clinic assessment and direct in-clinic resources accordingly, the figures in red here. So remote follow-up, let's begin with remote follow-up. This is the first model of remote patient management. So the patient has a device at home. This is an inductive system, applies the programmer, applies the wand to the device and transmits via a secure telephone line to the clinic. Importantly, this requires patient-clinic coordination. So sometimes this takes time. In fact, when we measured it, this took a huge amount of time. Patients used to forget their appointments. Sometimes the technology was not robust enough to permit an instant connection. So non-compliance and time required to find and communicate to a patient to come to the clinic and set up the connection often took an inordinate amount of time. So this can be a time sink. So this might increase clinic workload rather than reduce clinic workload, which is the intent of remote patient monitoring. Importantly, if adverse events occur, if there are problems that develop in the device or arrhythmias develop such as atrial fibrillation, which are asymptomatic, the patient will not know that they have to transmit this. And therefore, in a randomized trial, you can see here that the advance notice that remote monitoring of this form, remote follow-up, provided relative to standard care was 5 months. Early detection was defined as 5 months. And that is itself an oxymoron, because early cannot be 5 months. So what can we do? Inductive systems obviously have significant limitations. Well, the other evolution that has occurred is in fully automated technologies that perform daily sweeps of device monitored data diagnostics and transmit those automatically without patient or clinic interaction via a cellular network or a landline as available, with centralized analytics, and then provide important data for review by the clinic. So this represents state-of-the-art automatic remote monitoring. And it really takes the coordination between patient and clinic, appointment-based schedules, out of the equation. So this holds significant promise. So automatic remote monitoring was tested in the TRUST trial, and that was published over 10 years ago now, with randomized trial, conventional follow-up in the upper arm with 3 monthly checks in ICD population, and remote monitoring for a year. Remote follow-ups were carried out at 6, 9, and 12 months, but no in-clinic appointment was arranged for 1 full year. So this was safe. There was no difference between the randomized arms in terms of safety. Adverse event-free survival was virtually identical. However, remote monitoring here progressively reduced the number of in-clinic visits, so decompressed already saturated clinics for managing patients with CIEDs. Reduction was almost 50% at 1 year and continued to increase. Importantly, with this technology of automatic remote monitoring, patient acceptance and satisfaction was excellent. Relationship with the healthcare provider, ease of use, psychological aspects, implication on general health, so the perception of the utility of remote monitoring, and overall satisfaction were all excellent. The significant advantage of automatic remote monitoring is early detection. And from the TRUST trial, these figures that are indicated in red, those developing problems, in the year when they had no appointments scheduled in clinic, the discovery of significant issues related to device or arrhythmia was significantly accelerated. In fact, median time to discovery was 48 hours compared to conventional traditional care of appointment-based follow-up of taking more than a month. And that occurred for silent events too, very important. So clinically asymptomatic events could be discovered very quickly. This holds significant promise for improving outcomes. So first of all, device function. If the device is automatically checking itself every day, well, when an out of bounds parameter deviation occurs, it can notify with an alert. Related to device function, obviously this is familiar to the audience. Lead fractures, T-wave oversensing, ATP for AF can all be notified early, with the promise that has been borne out in randomized trials that early detection will reduce patient morbidity, for instance, with inappropriate shocks. So this has a significant value. Remote monitoring has a significant value for early detection of asymptomatic events, which can lead to reduction in patient morbidity. What about disease modification? We have devices which have an increasing capacity for collecting important disease-related data. Here we see a standard interrogation of a patient presenting with heart failure. And you see atrial fibrillation occurring 3 months before presentation, ventricular rates, loss of biventricular pacing, patient activity going down, thoracic impedance increasing. So this holds a promise that if we had early detection 3 months earlier, we might have been able to act on the first inciting event here, which appears to be atrial fibrillation, and prevent this downward spiral leading to heart failure and then clinic admission. So this has been borne out recently using the CardioMEMS device, which is an implantable pulmonary artery sensor, records pulmonary artery pressures, and patients can transmit this every day, so again, daily monitoring. And in patients with CRT therapy here, for instance, we found that medications adjusted in response to pulmonary artery pressure changes reduced high pulmonary artery pressure, so this is best medical therapy without the benefit of remote monitoring, and this is remotely controlled medical therapy. So up and down in diuretics and changes in guideline directed medical therapy. Area under the curve for pulmonary artery pressure and absolute pulmonary artery pressures all came down. What was the impact? So the impact was a reduction with treatment with remote monitoring on heart failure hospitalizations. So this shows that when you monitor, and this is not a therapeutic device, this is simply a monitor. So monitoring of a relevant, actionable signal that can permit an interventional therapy can improve patient outcomes, disease-related outcomes. So this is a significant finding amongst patients who have implantable electronic devices. So the current standard, given all the advantages that I've shown of remote monitoring, and this was published in 2015 by the Heart Rhythm Society, was that a strategy of remote monitoring and interrogation should be recommended in preference to a calendar-based schedule of in-person evaluation alone. Class of recommendation 1, level of evidence A. So this means after implant, we follow patients regularly with 3 monthly remote interrogations, 1 yearly in-clinic interrogations, and interim alert management for device or disease-related function. So the question that I shall ask is, what is the value of these regular evaluations during continuous remote monitoring? And this is a question that is surfacing in recent months, prompted by publication of some trial data. And this is the Japanese at-home trial, randomized trial of post-implant pacemaker patients, all of them committed to remote monitoring, and the test group no in-clinic evaluation for 2 years, a non-inferiority endpoint. And the conclusion was that scheduled in-office evaluations may be extended to at least biennially when employing effective remote management. So we can go to remote monitoring, remote patient management alone. But do we need the remote follow-ups? So this is a recent analysis of the TRUST trial, contrasting conventional follow-up here every 3 monthly in-clinic visits, and then remote patient monitoring only calling patients in for an actionable event. And the term actionable means a evaluation that prompts a change in medical therapy or device programming. So this is a very important metric of the value of a device evaluation of a patient who has a device and whether that in-clinic or remote check is required. So the data are fascinating because the actionability of clinic visits in conventional care here for scheduled 3 monthly checks was less than 10%. So by and large, they are unnecessary. In practice, unscheduled checks had a more than 3-fold increase in actionability. So this structured appointment-based care doesn't discover a significant number of problems. And that is not surprising. Problems will not occur on a calendar-based schedule. They will occur in between. So as a result, alerts become much more significant. Alerts had a 50% incidence of actionability, alert-driven care, when alerts were adjudicated via centralized analytics, and then those data were transferred to the clinic. So this shows that when you have this system of remote patient monitoring, you can reduce unnecessary clinic visits by more than 80%, so significantly decompressing saturated clinics. So in conclusion, I would suggest that routine 3-monthly in-clinic follow-up evaluations are inconvenient to patients with CIEDs and pose high workloads to clinics. And these are largely non-actionable, and they miss interim problems. So it's not a very efficient form of care. Continuous remote monitoring, on the other hand, is simpler, more convenient, and better achieves the aims of follow-up with improved outcomes in CIED patients. So a strategy of remote monitoring with centralized analytics without appointment-based follow-up, appointment-based whether it's in-clinic or remote, this system may prove to be safe, effective, and efficient, and ease the burden on ICD clinics, and also improve outcomes of patients. Thank you very much.
Thank you very much. I'd like to thank Dr. Varma for his presentation, and sorry that he couldn't be here with us for any discussion afterwards. We're going to move on from that, which was a great review of the benefits of remote monitoring, into the dissemination of the idea of remote monitoring in a Canadian perspective. I've had the pleasure of working with Radhika Parkash in many different ways on the Canadian Device Committee for quite a few years, and when I was part-time out at Dalhousie. She's one of the biggest proponents of remote monitoring only, and is working on a lot of projects in that regard. And so no further ado, please, Radhika.
Thanks very much, Larry. I'll share my screen here. Hopefully it all works. Okay, great. Thank you very much to Dr. Crystal for organizing this and inviting me again to speak. It's always a pleasure. We don't get to ski this year, but that's okay. We'll get it another time. And thanks to Dr. Stearns and Baranchuk for chairing the session. So this is a perfect segue, or Dr. Verma gave me a perfect segue into the topic that I'm going to cover today, and that is remote monitoring in Canada. We have taken the sentiments that Dr. Verma has outlined and run with it, is basically the best way to put it. So I'll be able to provide you with some of the work that we've done in this regard to really move towards a virtual way of managing patients with CIEDs in Canada. So let's start with some of the data, Canadian data, regarding what proportion of patients currently with patients with ICDs actually use remote monitoring. Unfortunately, we can't have audience participation, so I'll answer the question for you. In a study that we did of a device under advisory as part of our Canadian Registry of Electronic Device Outcomes, the Abbott ICD was under advisory. We looked at that issue in 2,678 Canadian patients involving most centers in Canada. At the onset of the study, 64% of patients were on remote monitoring, and at the end of the study, where the CHRS had recommended remote monitoring, it was 83.7%. So it's the answer to this question is somewhere between 60 to 80%, and likely higher in the current era. Now, what proportion of patients with pacemakers in Canada use remote monitoring? This data is a little less robust, but we did do a study of patients looking at the use of remote monitoring in pacemaker patients. And when we started the study, none of the 97 patients that participated were on remote monitoring prior to enrollment. When we surveyed device clinics across Canada, there was 22 clinics across Canada, varying geographies of the country. Only half the clinics utilized remote monitoring at any time for pacemaker patients. And that doesn't tell you the number of patients that were actually on remote monitoring, just the number of clinics that were actually using it. for pacemaker patients. From my knowledge, only Montreal puts all of their patients only on remote monitoring for pacemakers. I'm not aware of other centers that do that exclusively. So it's probably somewhere around less than 20% currently in Canada. Now, some other facts about remote monitoring. The first thing is remote monitoring has been shown to improve mortality in patients with ICDs, and we'll discuss that as we get into the talk here. Okay, and then the last question is, which of the following is true regarding remote monitoring? Remote monitoring reduces workload in device clinics. It's welcomed by patients as it improves their level of security. It can detect clinical events earlier than conventional follow-up. And I think that Dr. Varma addressed these in the prior talk, and we can answer number 4. And again, we'll have some data around that. Now, what do the current guidelines in Canada recommend? We learned of the guidelines in the United States, but our current guidelines with remote monitoring date back to 2013. Raymond Yee put them together. So these are the current ones. The answer to this question is number 4, all of the above. So we recommend that device follow-up clinics integrate remote monitoring capability into their routine functions and include this service as standard of care. We suggest that patients in whom no device issues are not identified, routine follow-up is done in a 1-to-1 ratio, alternating assessments between in-clinic and our remote monitoring. And we recommend that device follow-up clinics develop the infrastructure, resources, policies, and procedures to optimally support the remote monitoring program in a manner analogous to in-clinic assessment. And this remains an issue to this day in Canada, where not all provinces actually fund remote monitoring. BC recently received funding. Ontario, I believe, still does not have funding. We have funding in Nova Scotia, and I believe Alberta does as well. So we don't have a national program that adheres to these recommendations at this point in time. So let me tell you some of the data that we've collected in Canada. We did, as I said, a survey of 22 device clinics across Canada. Those are the provinces. You can see there on the slide. So 80% of clinics used remote monitoring for their device patients. And again, that's clinics, not patients. And some of the quotes that we received from our key informant survey said that I think it's just a better way to run a clinic and just do good care for patients. I think it's a valuable resource, underutilized, underrecognized, and it is the wave of the future that we should embrace more completely. And then from our patients' perspective, 91% of patients said it was very important to receive a phone call from their device clinic after a remote transmission has been received. So this information was very useful for us as we tried to go further in sorting out how we can maximize and optimize remote monitoring for Canadians. Some of the barriers that we identified have been outlined already, but limited funding policies, lack of a unified process-specific and guideline-supported approach to follow-up for devices, accessibility for all patients and types of devices. In rural Canada, access to Wi-Fi and cell-based transmissions is not universal. There are issues with resources for device clinics as well as others, coordination of care, logistics of getting the visits sorted out, and then the attitudes of patients toward remote visits. So we do have some more data on what patients think in terms of remote monitoring and device follow-up. So one of the questions that we asked patients in the survey, there were 512 patients included in this, was, are there any cost issues that interfere with your device follow-up? And as you can see here, there was a significant difference in younger patients, indicating that there was cost issues that interfere with their follow-up. And then the next significant finding was that patients who lived further from their device clinic, their device follow-up clinic, incurred cost issues. I mean, you can just imagine a patient who has to drive 200 kilometers to get to their device follow-up every 6 months. Maybe somebody has to take a day off, and that can incur significant costs to a patient. In terms of satisfaction with device clinics, patients were mostly satisfied. Again, younger patients were a little less satisfied, but overall, over 90% of patients were satisfied with the device follow-up. And then finally, we asked the question, would you feel secure if you did not have to go to the hospital to have your device checked? And again, younger patients were more secure to not have to go to the hospital. And again, these questions were asked in an era where there was no or little feedback given regarding their remote follow-up events. So a patient transmitted a remote monitor to their clinic, but they may or may not receive a follow-up phone call, which they indicated was very important. So just keep that in mind as you interpret these results. Some of the quotes we got, this was a very interesting one. We had a patient write all over his questionnaire, and I liked what he said. He said, I got no feedback as to how the device was working or what the data was telling you about my health. At least when I have a live person gathering the data, I get some response as to how the device is working. Presumably there's more data that can be given to me about my health, but not getting any information was annoying. Most of the time, I'm a no news is good news sort of person, but a comment that such is the case is always nice. So again, this was a written sentiment, but looking at all of our data that we derived from the survey, this was the sentiment of most patients, that this is what they're looking for. So we did embark on a remote monitoring only study, just as was mentioned in Dr. Varma's review. We did a study, it was a pre-post comparison, it wasn't randomized, where we put patients into a remote only follow-up schedule. At 12 months looked at the composite endpoint of death, stroke, and cardiovascular hospitalization, as well as device-related hospitalization. We got a rate of 7.3%. In comparison to the literature, if you look at the TRUST study or any of the studies done that were randomized, their event rates were around 15%. So we were definitely well below that from a safety standpoint. We were able to reduce in-clinic visits for patients with defibrillators up to 58%, so down from 75% patient visits to 44%, again, similar to what has been shown previously. And the projected savings to the healthcare system was gigantic, $660 per patient per year, amounting to $23 million of savings over 5 years. So right now in the COVID era, we can definitely use this money. One of the stipulations that we made in our study, even though it was a pilot, is that patients must have had follow-up with a cardiologist or specialist. And that's in recognition of the fact that many patients in Canada use their device clinics to actually monitor their heart issues, their heart failure and so on, which we as a group of electrophysiologists find it very difficult to manage, and also find it not appropriate in a short visit of 10 to 15 minutes to be able to look after a complex heart failure patient. I'll just skip over to another thing. This is in reference to the data around mortality and its association with remote monitoring. This is a cohort study we did, again, looking at patients who were in the Abbott ICD advisory, so 2,678 patients. And we've made a very interesting observation. We found that patients who were on remote monitoring at baseline had a significantly lower mortality than patients who were not on remote monitoring at baseline. And this has been observed in other cohort studies. I just wanted to show you some Canadian data, but there is American data in this regard. And there is one randomized trial that did reduce mortality with remote monitoring. And we think that it had to do with the fact that they were able to detect heart failure and atrial fibrillation earlier and prevent events, just as Dr. Varma had indicated. So this data is real. You know, this of course is not randomized, to keep that in mind. And there is, but even when you adjust it for differences of patients at baseline, this still remains significant. I will go over this data quickly because it was covered in some detail already, but this is a systematic review on mortality for remote monitoring. And when you put all the trials together, it certainly favors remote monitoring. It does cross a unity, but the in-time study was the only one, as I said, that focused on, that did show a significant reduction in death in patients who are on remote monitoring, and that was a randomized comparison. As we've already seen, the remote monitoring reduces inappropriate ICD shocks. It improves atrial arrhythmia detection. It improves the time to clinical event detection. So many benefits beyond just mortality, which of course is very important. We learned from the most recent pacemaker data for at-home monitoring. This is an older trial called COMPASS, which was the first trial to be done in pacemaker patients. And again, found this similar finding where they were able to reduce interim follow-up significantly and no issues with safety. It was a non-inferior study in that regard. This is the Japan at-home monitoring study, which we've already reviewed, so I'll skip that. So that brings us to our Canadian trial that we're currently pursuing with the Cardiac Arrhythmia Network. We've got two parts of the trial. We've got patients with high voltage devices and patients with low voltage devices. We plan to enroll 2,000 patients to a strategy of remote monitoring along with virtues, which I'll explain shortly, standardized programming, and as specialist follow-up, as I indicated previously, we must have proper physicians following these patients if they're not going to be seen in person, versus standard of care, which is defined as a one-to-one blended follow-up with in-clinic and remote monitoring. So patients will be randomized. It's a non-inferior study. So our non-inferiority on primary outcome of time to response to alerts and device issues, along with safety to ensure that we're non-inferior from a safety standpoint. We also are looking at cost effectiveness and quality of life as secondary endpoints. The pacemaker study is very similar, but the primary outcome for that study is cost effectiveness only, as we've already proven the primary outcome in the COMPASS and the Japan at home trial. So the purpose of virtues, and again, I'll try to explain that as quickly as I can in the time we have, but the purpose of this entire study is sixfold. We want to improve patient quality of life. We want to detect arrhythmias more rapidly, or at least as rapidly as our current system. We want to have virtues, which is a virtual system platform that we give to patients, physicians, and device clinics. We want it to focus on device programming and its optimizations, decreasing inappropriate shocks through shock reduction programming. We want to give immediate feedback to the patient as the patient's requested. We want to give immediate feedback to all physicians participating in the patient care. And we want to have medications reviewed to ensure heart failure optimization where appropriate, as best as we can when we're not seeing the patient in person. This is especially important in the COVID era where we aren't seeing patients in person in many cases. So virtues is really coming on at a very critical time. We hope to improve heart failure care as we feel that this will no longer be done haphazardly, but patients will be required to have cardiac care since they will no longer be seen in person for their device. We expect this to be as safe as in-clinic visits, and we expect enormous cost savings, which are crucial to survival of our healthcare system. So what is Virtues? Well, Virtues is a platform that basically in the context of cardiac devices in Canada takes a remote transmission, uploads it into the portal. All of the patient's information is contained within that portal. The physician is contacted to know that there is a transmission for them to review. This is the front sheet that the physician sees. They have information about the patient. This is, of course, not a real patient. They have information about the device. There is information that we have regarding longevity, pacing settings, tachy settings, and percent pacing, and so on. All of the patient medications are available for review immediately. And that's that information gets reviewed by a physician or a nurse practitioner, whichever is being done in the particular center that's participating in Virtues, and it's sent back to the patient. And all of that, we've measured the time it takes for a physician to review this information is done in 30 to 45 seconds. So the time delay is getting to the transmission, but once the transmission is looked at, it takes about 30 to 45 seconds to read it with all the patient's information at hand. And so on the left here, you can see that all the patient information that we include, including lab work, a frailty score, and so on. All of this was put together with input from device experts across Canada, as well as patients. So this really had a lot of input from many people. Again, I'm going to go a little quick on this just for the sake of time. We're running out of time. And then a green, yellow, or red light goes back to the patient to let them know of the status of their device. And again, this is immediate. Once the submission button is hit, down here, it goes right to the patient. And then the patient, I'm going to skip to what the patient actually sees. This is what the patient sees. They get a notification that there's a new report available. A little red light comes on their bell, and they're able to see what that physician thought about their transmission. So whether it's a green, yellow, or red light. And we've had some yellows already in this study. We've got about 170 patients randomized in the study. We've had some yellows and some reds already, and no negative feedback from anybody so far. So we're going to keep going. So I will stop there. RM is here to stay. We have to embrace it. We have to make it better. We have to improve our standards and quality of care to manage our incredible workload that we have these days with patients with devices. And we'll use virtues to get to that end game. Thank you very much.
Fantastic, Radhika. Thank you very much. In the interest of time, we've been asked to move to the QA session, but Adrian and I had two real quickies, if you can try and answer them fairly quickly. As you know, we've been trying to get our center up and running with the RPM studies, and the hospital's biggest stumbling point was privacy concerns. Have you had any troubles with patients accepting this? Do they worry about giving up their privacy when they go fully to these remote profiles, or are they quite accepting?
We have very few patients that have had any issues from a privacy standpoint. In fact, as you know, some patients refuse remote monitoring, period, because of the fact that the data is held in the United States, right? So their data goes to US servers, US-based servers. They're subject to the Patriot Act. And so the refusal problem is more at that end. All of our data is held within Canada, and the patients know that their information is in there, and they're signing consent, and they are fully aware of the implications. So to date, we've had very little in the way of refusal. We are keeping a screening log to sort that out, because that's an important concept. But the idea here is that patients are getting more out of this than they are getting, for the most part, from their device clinics and their device follow-up. So I think that there is a major impetus for patients to go. So, but I'll get back to you on the refusal rate, because I think that's an important consideration here, because if only half the patients are interested, we've got a problem. But we have not observed that. Again, that's anecdotal. I don't have the actual data.
Thank you.
Thanks, Radhika. It was a fantastic talk. I have a couple of questions from the audience. This one is from Laura De Souza, and she is concerned that in patients either with ICDs or pacemakers that are being paced, you are unable through remote monitoring to learn about their underlying conduction. Can you quickly give us a quick perspective on the things that you could miss by replacing in person by remote?
Right, that's an extremely important concern, and we have the same concern, particularly in pacemaker-dependent patients. Now, in our pilot study, we excluded pacemaker-dependent patients for that exact reason. In this study, what we are doing is we are ensuring that patients have appropriate capture management or auto capture turned on, ensure that it works in a dependent patient and that it's reliable and that we trust it. If that is not the case, they're excluded for now because of safety reasons. Those patients are very, they're scary to me to have a patient who is dependent and we don't have good information regarding those features. So if we're not satisfied that those types of features are working on the pacemaker, we're only enrolling Medtronic and Abbott. So it's capture management and auto capture are the features that we have to work with. Then those patients are excluded. So that is an exclusion criterion for your safety concern, and I totally concur. So what I hope to see is that we can do better with keeping pacemaker dependence safe through remote monitoring. But using our current technology, we have to work with what we have.
Very good. And a quick from Satish Rash is that his impression is that the remote visit for the nurse does not take much less time than an in-person. Can you give us your experience, please?
Yes, so that's a very good point, Satish, and we actually haven't measured that particular thing. I just have anecdotal data again from our clinic where they say it takes about as much time, maybe 5 minutes less because you don't have to hook the patient up to the monitor. So yeah, you're right. From one of my problems with remote monitoring is that we have inserted it into our practice without removing anything. So I don't think we removed enough to bring remote monitoring in to actually realize that the time and cost saving that it should be giving us. So you're right. Now, one of the other things that we should consider here is the concept of machine learning and the concept of being able to take a remote transmission and read what it says without humans involved and doing that with certainty. And that's one of the things that we started doing as part of the Virtues CIED study, the RPM study, as Larry referred to. And we hope to continue doing that and doing it better. Because that would indeed cut down on technician or nursing time to review those transmissions. And it's a very important point. As you know, everybody's device clinics are tripling because everyone's living forever. So we've got all these people out there with defibrillators and pacemakers to follow.
I will pass it to Dr. Larry Stearns, President of the CHRS, to close this session, and then to Dr. Krista. Thank you so much, Radhika.
Thank you, Radhika. That was fantastic. Thank you to Dr. Varma as well. We're a little over time here, so I'm going to very quickly go to Dr. Crystal and on for the QA.
All right. Thanks a lot, Larry. Thanks to all speakers. Radhika, your talk was so absolutely fantastic. Thank you. My only comment, I think it's time comes to ask, hey, Alexa, how is my pacemaker? Or hey Siri, how is my pacemaker? In other words, whatever we do has to be at least partially patient initiated, right? Yeah. Thanks a lot. We then concluding winter school first session at that point. Our next session would be in several weeks. You will get emails. I encourage everyone to help us with evaluations. I'm very grateful to faculty and all technical help we got. And I encourage everyone to stay around for the absolutely mind-boggling session on robotics and electrophysiology, where you will see several best newspapers, several new papers on both physics of automation and clinical experience with automation. Thank you.